Right. Right, you can go.
O'r pawb, croeso I cyfarfod bod iechyd Prifysgol Betsi Cadwaladr. Welcome everybody to the meeting of the Health Board today. The fact that the meeting is once again being live streamed to enable members of the public to observe the meeting in real time. Members are also welcome to contribute in the language of their choice, as we have Lowry here to provide Welsh to English translation, which we've just checked is working effectively. So in terms of my introductory remarks, I want to record a number of Chair's actions that have been taken since the last meeting. The first is that there was a Health Board Chair's action completed on the 27th of May regarding the tender for the redevelopment of the critical care unit at Wrexham Minor. The second is that there was a dual F&P Committee and Health Board Chair's action completed on the 15th of June regarding the recommissioning of orthodontic services in Penrhyn Deirdre. Thirdly, Health Board Chair's action completed on the 23rd of June to endorse the SRG election of Chair and Vice Chair to allow ministerial approval to be attained for the Chair's position, which is still awaited at the moment. Fourthly, Health Board Chair's action completed on the 3rd of June to approve acceptance of the recommended tender for the reinstatement works following the decommissioning of Ysbyty and this Llandudno. Fifthly, dual F&P Committee and Health Board Chair's action completed on the 21st of June to approve contract with Lightfoot Solutions to provide healthcare consultancy and specialist technological services to aid winter planning and delivery and ongoing support. Sixth, Health Board Chair's action completed on the 25th of June for authority to settle a claim of over £1 million. Seventh, the Health Board Chair's action completed on the 5th of July for approval of acceptance of the recommended tender for the reinstatement works following the decommissioning of Ysbyty and this D-side. Okay, there's nothing else I want to say at the moment by way of introductory comments. I'll move on to apologies for absence. And I've got apologies noted from Adrian, and we have David Fletcher attending for the link item in the private committee meeting later. Sue Green, and I've got Leslie Hall with us today, deputising for Sue, Morwenna Edwards, and also to note that Joe and Lucy, the Vice Chair, are not with us at the start of this meeting because they are attending a North Wales Cabinet Committee meeting with the Minister as we speak. So I will then move on to declarations of interest. Are there any declarations of interest? No, thank you. The draft minutes of the last meeting have been circulated. Is everyone content with the accuracy of the minutes?
Yes.
Yes.
Okay, thank you. I'll turn our attention then to the action table, which has also been circulated. And stop me if anybody wishes to comment on any of the actions. So the first was with Chris from the 30th of March meeting, it's shown as closed. The second was with Jill from the 22nd of April meeting, which is shown as closed, but no doubt is the subject of ongoing attention. The third was with Jill as well from the same meeting. The next two were with Teresa and Jill respectively, 20th of May. And the next is with Jill and is shown as still open. Jill, is there any comment you want to make about the milestones in terms of vaccination and the fact we're going to meet them at this point?
So Mark, can confirm that we are meeting the milestones for vaccination, but I'll come on to more of that during the COVID update, if that's okay.
Of course, yeah, thank you. And then we'll move then through the other actions. I won't draw attention to all of them, but they're all shown as closed. Are members happy that those actions have been closed?
Yes.
Yes.
Okay, thank you. So we'll then move on to Joe's report as Chief Executive Officer. It has been circulated. As I say, Joe is not with us. Before we note the report, Jill, could you make comment on the letter that's recently been received from Andrew Goodall following a joint executive team meeting, please?
Yes, Chairman. So the executive team have been involved recently with a joint executive team with Welsh Government meeting We have now received feedback from that meeting from Dr. Andrew Goodall, and very positive response to the meeting and the progress that we are making, and the positive response to targeted intervention as well. So the team were able to not only present quite very cohesively on the day what our ambitions were and objectives were, but the comment that was made in the letter as well was of the supporting information that provided evidence of the actions that we're taking, and that was commented upon in the letter.
Okay, and the board members have seen a number of letters of that nature, but I have to say, and I hope that members will support me in saying this, that I think it's the most positive letter that I've seen since I've been in position from that joint JET meeting. So the executive team and the organisation should be commended on the way that meeting went and the positive nature of the feedback provided by Andrew and his team. Okay, so we'll move on then again, and it is, Jill, to the update on the COVID pandemic.
Thank you, Chairman, and I'm sure that colleagues around the table will want to contribute to this. The presentation is before you, and I don't intend to go through every single slide, but I will pick out some key points and give you some more up-to-date figures. So what we are seeing is very much the Delta variant of COVID is very much present in North Wales, and we're seeing that we're ahead of the curve of the rest of Wales for COVID at the moment. And if you recall, we've always been slightly behind South Wales, but this is reversed at the moment. We are seeing a plateauing of the cases across Wrexham, but we are still seeing very high numbers of cases across the whole of North Wales, although positively, Gwynedd and Anglesey are no longer in the top 10, so that is positive news for us. We are still seeing patients being admitted to our hospitals, and at the moment we've got a total of 33 in our acute beds and 41 in our community bed, 8 in our community beds, giving us a total of 41. So we are very much seeing that we are still seeing evidence of COVID in the acute hospitals, and we are still managing our red and green pathways. In terms of primary care, we are continuing to increase our virtual, our face-to-face alongside consultations which are virtual, and we are seeing an increase in activity. They are continuing as well to support the vaccination programme. I think it is worth saying at this point that the impact of COVID and the Delta variant on our staffing has been quite significant. So the need to isolate as a consequence of a positive contact. The latest figures I had show in excess of 130 staff being isolated as a consequence of that, and that is across all our services, and generally happens in clusters, so it is impacting our services and continues to do so as part of that self-isolation. And that is proving a challenge because it's impacting our primary care vaccination programme as well as acute and community services. So also worth noting that we are seeing some care homes who are seeing patients who are testing as positive, or residents testing positive. And whilst many of these are not necessarily displaying significant symptoms, it does reduce the bed availability in our wider community service and care homes. So again, that is having an impact. We have had an outbreak on one of our wards in the mental health unit. That has been well contained, and we've had a cumulative total of 9 patients and 4 staff as of the 11th of July. But that has been very well contained, and I want to thank the staff involved in that unit for the way that they have managed that outbreak. So we have also updated our visiting guidance, including that to maternity visiting, but that is always subject to review given the current situation. So we're managing that very, very carefully. And we do have escalation plans for all services, including critical care, should there be a requirement for those as a consequence of the third wave that we're beginning to experience. So in short, Chairman, we do have risks around our staff availability due to the risks of isolation. We are seeing Delta variant is the variant in North Wales at the moment. It is very much present, and the risks are still there. And as we come out of a lockdown scenario, we are still very carefully having to manage the risks of infection across the whole of North Wales. Test and trace, Teresa, I don't know whether you want to come in at this point. I know it's your first day back, so if you don't, I fully understand.
Hi Jill, diolch yn iawn, na I siarad yn Gymraeg a speak in Welsh. Mae wedi bod yn brysur iawn yn y byd profi yn arbennig. Mae yna alw cynyddol erbyn hyn ar profi ar draws Gogledd Cymru, ond mae gynnon ni nifer o ffyrdd i brofi a da ni ddim wedi ffeindio problemau mawr, ond staffio wrth gwrs ydy'r problem sydd yn herio ni gyd. O ran y gwaith online, maen nhw wedi mynd i fewn i surge fel tîm. Da ni wedi gorfod rhoi fwy o staff i ategu'r y staff sydd yna'n barod i wneud yn siŵr bod ni'n gallu cyflawni'r galw. Fel da chi'n deud, Jill, mae yna nifer o staff yn gorfod hunan ynysu ar hyn o bryd. Wrth gwrs mae hynna'n effeithio nifer o wasanaethau ar draws Gogledd Cymru. Nid yn unig o fewn y byd y maes iechyd fel petai, ond hefyd yn y gwasanaethau cyhoeddus fel arall, mae o'n herio ni. Ond wrth gwrs mae'r tîm o'r-lein yna i cefnogi ac i cysylltu hefo'r unigolion fel bo angen. Bwysig mae'r gwaith amddiffyn yn dal i ffynnu. Mae 4 o'r hubs erbyn hyn wedi i sefydlu, a da ni'n ddiolchgar iawn i'r partneriaid sydd yn rhan allweddol o'r gwaith yna ar draws Gogledd Cymru. Dwi'n meddwl mae'r risg fwyaf i'r gwasanaeth gan fod i mor brysur ar draws Gogledd Cymru ar hyn o bryd ydy'r staffio, oherwydd mae salwch yn effeithio pawb, ond hefyd wrth i ni fod yn trio cynnal gwasanaethau cyffredinol, mae hynna yn herio ni yn gyffredinol o ran TTP hefyd, a da ni wrthi yn edrych unwaith eto ar y staffio ar gyfer yr hydref sydd o'n blaen ni. Wrach na I stopio fan'na, Jill. Diolch.
Thank you, Teresa, and I know that the staff have been working incredibly hard given the requirement for testing that's been going on as a consequence of the variant. So moving on to vaccination and coming back to your opening comments, Chair, about our achievements against the milestones. You'll see from the slides that we have achieved the milestones and we have offered all adults age 18 and over the vaccine. We have as well, we are continuing to really promote the vaccine. I'd like to thank our local authority colleagues and others who are supporting us in promoting the vaccine. There still is a very, very serious virus that we're seeing, and the implications if of people who are now not vaccinated and are seeing having been diagnosed as COVID, we are still seeing very severe symptoms in many of those. So in the vaccinations going forward, we now have online booking open to all, but we are targeting those very high risk groups, the hard to reach groups, and a lot of work has been undertaken to support those who are unlikely to have access to online booking, may be reticent about coming forward to have the vaccine, So there's an awful lot of work to ensure that we are reaching out to those hard to reach groups. We are now finalising the mass vaccination centre. You'll know that we are moving away from, we have moved away from the university building in the west. So you will see that the vaccination centres we now have in the west are Bangor Cathedral, which has been received very positively, Carnarvon Tennis Centre, Dolgellau Leisure Centre, Ysbyty Achwen, and Ysbyty Penrose Stanley. So those are our vaccination centres in the west, whilst we do also have GPs involved in the programme. In the centre, you'll be aware that we have Venue Cymraeg until the 31st of July. But whilst that has, while we know that that is closing, we have been accessing, capacity elsewhere. So we now have the Optic Centre, which has been available from this week. Argyle Road in Llandudno will come online on the 4th of August. Kinmel Bay Community Resource Centre, the Community Centre at Rhyl, Wellington Road. We also have them in Denbigh and Colwyn Bay. East, we continue with our Deeside and Catherine Finch, but we're also working with Plasmadok Leisure Centre and the British Legion Centre in Cley. And for the public who wish to access that, these details are constantly being updated on the website. And I would take this opportunity, Chair, to reinforce that our vaccination programme is still very active, and we would urge everyone to come forward and have that vaccination if they haven't done so to date. So in terms of long COVID, there's a lot of work going on about the implications of long COVID, particularly around how many people that this is going to impact. But we are seeing that that this is very real, and that suggesting that the prevalence of at least one symptom for 12 months or more ranges from between 2 and 10% in the community, and 70% if they've been hospitalised. So it is very, very real. We are now working on a business case and development for regional long COVID to ensure that we've got multidisciplinary teams available to support those individuals who are living with long COVID. And we have actually developed a self-management programme, which we're very proud to have been the first to do that in the UK. The national progress, there is a long COVID app which is being downloaded. So again, that is available to people, and the information is being updated again on the All Wales website. I'm happy to take any questions, and I'm sure colleagues will join me if there are any that relate specifically to their areas. But what I would emphasise is we've got a very real issue with the Delta variant in North Wales. It is very much prevalent. It's not, it is the variant that we are seeing in North Wales, and we are still seeing hospitalisations, and we are definitely seeing the impact of it on our workforce and wider workforces across North Wales.
Okay, thanks, Jill. First question is from Medwin. Medwin.
Thanks, Mark. And obviously we all appreciate the work that's going on in the background. I mean, decommissioning a site and then commissioning another site is not an easy task at the best of times. And I'm sure we all appreciate the work that's going on in the background, Jill. You may or may not be able to answer this, but I think it's a question that the public need to know the answer to, in terms of, and it could be because of patient confidentiality, because the inpatient numbers at the moment are so small. The question that many people will be asking are, have these people been vaccinated and double jabbed? Or have these people who have been admitted to hospitals, those who haven't for whatever reason, maybe personal or maybe medical grounds, underlying conditions that they may not be able to get the job? Do we know the breakdown of the type of patient of the 41 who are in sites at the moment, whether they've been jabbed or not?
So, Medwyn, I don't have the precise numbers, but the evidence we are seeing is those people that have had a jab and certainly been double jabbed are on the whole, so the vast majority of those are seeing less acute symptoms than those who have not. I don't know, I'm looking to Teresa because she might have some more detail from a public health perspective.
Diolch, Jill. Thank you. Dwi wedi clywed dim byd yn wahanol I be mae Jill newydd I ddeud, Medwyn, yn gyffredinol, y newyddion ydy dal ati gyda'r brechu. Mae brechu I weld yn amddiffyn yn dda yn erbyn y variant Delta, fel mae Jill wedi sôn yn barod, sydd yn lledaenu ar draws Gogledd Cymru. Sgynna I ddim pryderon mowr, yn bendant mae Covid yn dal I effeithio ar pobl yma yng Ngogledd Cymru. Niferoedd llai na sydd wedi bod, ond dydw I ddim yn bryderus a mae Jill wedi rhoi'r ymateb swn I wedi dweud ynglyn â'r brechu a sut mae'n amddiffyn cleifion. Newydd ddod yn ôl dwi, os gynna I ddim manylion ynglyn â'r cleifion sy'n yr ysbyty erbyn hyn, ond yn bendant dyna dwi wedi gweld o ran wybodaeth iechyd cyhoeddus yn ddiweddar.
Iawn, diolch Teresa. Mae'n wrth gwrs pryderon tu allan i'r byd iechyd tu allan I byd Betsy. Mae'r cyhoedd yn gofyn y cwestiynau yma pa mor effeithiol ydy'r vaccines yma ac wrth gwrs maen nhw'n pryderu os ydy'r niferoedd ysbytai mynd I fyny hefyd, ond diolch am yr ateb. Mae'n cwestiwn anodd I ateb yn gyhoeddus dwi'n darllen hefyd, ond dwi'n meddwl bod ni angen clywed beth yw'r ateb wrth symud ymlaen ynddo.
Ond swn i'n hoffi ymateb os gai ymryn fwy, felly mae'r brechiad yn effeithiol iawn. Dyna di'r peth pwysica allwn ni wneud erbyn hyn. Hefyd dilyn y canllawia, dal I ddilyn y canllawia ynglyn â hynny'n ynysu pa mae angen. Gwisgo'r masgiau fel bo angen, dwi'n gwybod fod y gwybodaeth wrth gwrs yn newid, da ni yn y cyfnod yna, ond brechiad ydy'r pethau pwysica allwch chi wneud ar hyn o bryd. Dyn da ni'n dal I annog pobl I fynd ati cael I brechu fel mae Jill wedi deud yn barod.
Diolch, thank you, Chair.
Just to add that we are open, we are accepting people who are walking in. If the vaccine is there, we are offering it to anyone who walks in.
Jill, just on the question, because it's been asked before, isn't it, by board members, and quite understandably so, and as Medwyn says, it's not just been asked by us. Why is it seemingly difficult to track information in terms of hospitalisation and whether the patients being hospitalised have been vaccinated or
not? Mark, I'll take the ask outside and provide it if I'm able.
Okay.
But I would say that certainly those with the severest symptoms, I would support Teresa's. The evidence is suggesting that those people have not been vaccinated or fully vaccinated, but certainly even one dose seems to be having an impact on the severity of the symptoms. So again, would urge people that the vaccine really is making a difference.
And of course, the board would want to reinforce that message as we have been doing throughout, Jill. But I think the correlation would help us understand.
Happy to work on that outside and we'll provide it.
Okay, all right, thanks. Jill. Avion.
Diolch yn fawr, Mr Cadeirydd. Na I siarad yn Gymraeg os gai. A gai diolch yn fawr iawn I Jill am yr adroddiad. A hefyd yn enwedig am ei gwaith ardderchog ar y system brechu ar draws Gogledd Cymru. A hefyd o'n i'n darllen yr adroddiad lle mae'ch gwaith chi ar Covid tymor hir yn un pwysig iawn hefyd. So diolch fawr chi am hynny. O'ch chi yn cyfeirio yn eich adroddiad bod ne 130 o staff yn hunan yn ysu ar hyn o bryd. A mae hwnnw wrth gwrs yn mynd i wneud gwahaniaeth sylweddol i'r gwasanaeth da ni'n gallu rhoi i'r cyhoedd ar draws Gogledd Cymru. Dwi'n dall bod Llywodraeth Cymru am adolygu yr angen I hunan ynysu am 10 diwrnod. Ella tynnu hwnnw I lawr yn sylweddol a hefyd wrach dileu yr angen yn gyfan gwbl i bobl sydd wedi cael ei ar yr ail frechiad. Beth ydych barn chi ar hynny a faint o wahaniaeth fysa hynny'n wneud i'r gwasanaeth da ni'n gallu rhoi? Diolch yn fawr.
Thank you, Ivan. That's an excellent question. I think our primary responsibilities is to protect both our staff and our public, and that very much our patients. So in terms of the question you ask, is in excess of 130, those numbers will vary day to day. I think the principles that we would be looking at is that we would want them to have a negative test alongside, but that would enable us to a PCR test, and then we could bring them back to work much sooner. Again, I think Teresa may have an opinion on that, but I think that's where we are. That's where we would wish to go, so that we reduce the length of time that people are self-isolating, recognising, of course, that many people will not have symptoms anyway, so this is a really difficult balance.
Diolch, Jill. Ia, yn yr un lle, mae'r criw profi ag orlaen, wrth gwrs, yn gweithio'n agos iawn gyda'r grŵp cenedlaethol i wneud yn siŵr bod ni'n dilyn yn canllawia. Mae yna oblygiadau, wrth gwrs, i'r criw profi ag orlaen wrth i ni newid yn prosesau, neu os oes yna newid yn prosesau'n symud ymlaen. Mae'n siŵr bydd y profi wrach yn cynhyddu i rei, neu rei ffyrdd o profi'n cynhyddu. A wedyn, wrth gwrs, be fydd yr oblygiadau wedyn i'r criw sydd yn orlaen, sydd ar hyn o bryd yn hynod brysur, mae'n rhaid deud. Ond wrth gwrs, mae'n rhaid meddwl am y risg o ran yn staff ni, o ran staff iechyd yn wedig, ac yn y sector gofal. Wedyn, mi fyddwn ni'n dilyn y canllawia, dwi'n gwybod gymaint o hynny wedyn. Dwi yn gweld yr angen i gael yr balans yn iawn o ran cadw y sector, y pethau'n symud ymlaen, ond mae o'n teimlo fel cyfnod o newid ar hyn o bryd.
Diolch yn fawr, ateb digon teg. Diolch yn fawr.
Diolch. Linda?
Diolch yn fawr, Mr Cadeirydd. Ga i jyst ofyn i Jill, a ga i ategu be wedodd Eifion ynglyn â'r holl gwaith ardderchog mae staff y bwrdd wedi bod yn gwneud trwy gydol y pandemig yma. Ond ga i jyst ofyn, wrth ystyried, mi fydd dipyn o ymwelwyr yn dod i Gogledd Cymru dros yr haf, ac i ddeud y gwir, mae yna ragwely'r fydd na mwy neu erioed yn dod. Oes yna unrhyw pryderon gen Jill ynglyn â y capacity ni i gallu edrych ar ôl yr ymwelwyr yn ogystal a bobl sydd yn cynhenid sydd yn byw yng Ngogledd Cymru? Diolch.
Again, excellent question, Linda, and thank you for posing it. We are absolutely seeing an increase in visitors across North Wales, and I understand it's topped the charts for the UK, actually, for a staycation destination. And we are seeing the impact on that on our emergency services. So we are routinely seeing a significant number of patients in our beds who are not local to North Wales. And indeed, they're also accessing our ED departments and minor injuries units. And the socialisation there brings its own risk in terms of COVID. And whilst we continue to manage that, and we're absolutely doing everything we can to support the messaging that is going out to our public. We are really, really conscious of the increase in volume, and we're seeing the increase in attendances in our ED departments and our other areas accessing care very much increasing. We're still trying to manage the red and green pathways, as I alluded to earlier, and that does put a challenge on our departments in terms of the testing as well, so we get the results back so we can separate. So it very much is putting up an increased pressure on all our services, and that would include our community services as well, Linda, and it is one that we are flagging.
Diolch yn fawr iawn, Jo. Diolch.
Okay, I can't see any other hands up. Jill, a couple of observations, questions from me. So the first is, as you described, the incident rates in North Wales are climbing, particularly now in the east. We've got the highest incident rates in Wales. Whilst we note the level of hospitalisation are nowhere near wave 1 or 2, they are still increasing slowly. So how concerned are you as a team about that dynamic, Jill? And what else can we do as a board to communicate any concerns that you have, either with the public or stakeholders? And in that regard, the First Minister was on Radio 4 this morning, and I thought he was very clear about what the expectations are as to the rules moving forward in Wales, and particularly around the wearing of face masks. But you will be picking up feedback, I'm sure we are too, and I've certainly seen it this morning in Mold, where people are clearly changing their behaviour and not following the expectations around the wearing of face masks, for example. So how concerned are you and the team, Jill? And is there anything the board can help you reinforce the messages?
We are concerned, Chair, and that's why we're looking at our surge plans. We're looking at the impact that may have on our inpatients. And again, as we've seen previously, it does have impact on other services, including our planned care, which we are desperately trying to treat those who've been waiting far longer than they should have done as a consequence of our initial long waits, but then compounded by COVID. The point I would reinforce, we've reinforced the need for vaccination, absolutely support the masks and the fact that we will be maintaining that stance within our own buildings in order to protect our staff and our public, and support of the board in that is going to be greatly appreciated. And I think in terms of it is about the public messaging, reinforcing the public messaging. I would ask that people don't turn off their ping, for want of a better term, that people do self-isolate it until that they can prove that they are not impacted if they have been contacted, because we are still seeing a significant risk. That is also compounded, Chair, by the fact that we are anticipating, and we've already had one small outbreak of other viruses impacting as we go into the autumn, late summer and autumn months. So we have already seen norovirus. Clearly we're thinking about how we manage the flu. So we would ask people to actually protect themselves, protect their families, and protect the health system. And whilst it is really, really difficult, everyone is trying to get back to normal and wants to get back to normal, we are still living with a significant risk.
Okay, so in terms of the messaging, Jill, I know there's a lot going out, but can you keep the board appraised of what is going out, please, in terms of the concerns that you've got and how we're seeking to address them? Because you know, there's clearly some poor behaviour out there. There may be some confusion too, so we've got to do all that we can as a board to address that. And are you having these conversations with partners as well, Jill, in the sense of some of these messages might more easily come from some of our partners?
Yes, so yes, we are, and they have been supporting that. They've been supporting the messages about behaviours, and they've been supporting the messages about vaccines. So yes, we are, and we're working collectively across the local authority comms teams as well. We're also sending out letters and information to tourist centres, so that we're getting the message across to those that aren't normal Welsh residents.
Okay, all right, thank you. And then second question from me, and it might be better for Chris to respond to this. So there's an update on primary care access in the presentation, but one of the biggest concerns that we are receiving a lot of correspondence about, and it's coming from staff and from people in our communities, is about access to GPs in particular, and the perception that behaviour has continued in terms of denial of access because of COVID, Chris, and that should start to be shifting now. What's your position on that, Chris, and in terms of where we are now and how we might move forward?
Thank you. So all the way through the pandemic, we have had processes in place which require people to contact and be triaged before then being provided with face-to-face consultations. And as time has moved on, the threshold for face-to-face consultations has appropriately shifted, and all of our GPs in North Wales are aware that there's no justification in any way to deny moving through to a face-to-face consultation where it's appropriate. However, often it still is not appropriate, and often it does present a risk to either individuals within the practice that then can see a practice having to close due to isolation, or to other vulnerable people being seen face to face. And so that triage process continues, and where it can be appropriately managed in other ways, other forms of consultation still occur. What I'd like to stress is that absolutely, if a face-to-face appointment is required, there is an expectation that that should be delivered, and our contractors are trying to do that. It's a difficult message to share sometimes, and there is this perception that maybe primary care is closed. In fact, it's far from closed. It's busier than it's ever been. There is a short video which is currently being shared on social media and through media outlets across Wales that has been produced by Welsh Government. We're putting the link for that on our website. It's very helpful. It's only about 20 seconds or so long, just explaining some of the reasonings behind triage and reassuring people that actually a face-to-face appointment will follow through if that is what is required.
Chris, given the increase in demand and the pressures being faced, in terms of sustainability of primary care services, what are you doing to examine that?
So we continue to expand the offer in primary care to beyond the traditional model of a GP and practice nurse. That's not to be dismissive of GPs and practice nurses, but there are many people that can do lots of those roles that might previously have fallen to them. And it's right and proper that those individuals are available to be consulted with too, and that people are appropriately directed so that they can make the best use of those different resources. It includes high street providers such as optometry and community pharmacy, but it also includes a whole raft of different professionals working within practices. And that means then that when you need to see your GP is focused more upon the things that only they can do and supported by that wider team. We do have recruitment programs in place for GPs as well as for all of those other professionals, and we will continue to move those through. But the short answer to your question is it is really tough. GPs and their staff are being very clear about prioritising the really important work that they need to do and sharing that across that wider team to have the greatest impact.
So just in terms of key messages then, Chris, so what we're saying is, in short, when one considers the number of face-to-face appointments, the number of calls being received by GP switchboards, add that to e-consult and other virtual mechanisms, generally the demand is significantly higher than pre-COVID. So as a consequence of that, we're wishing to keep triage in place to help deal with that demand in the most appropriate manner. But where it's clinically necessary for someone to see a GP, we'd expect them to be able to see a GP.
Absolutely.
Okay. Right. Great. Thank you. I think Cheryl wants to come in, Chris, before you stop. Cheryl?
Thank you very much, Chair. Thanks, Chris. I'd just like to ask, following on from that conversation, I speak to a lot of our residents and patients every day, and I'm finding that particularly amongst the older generation, there's a real reluctance to share a lot of detail with receptionists carrying out sort of the initial recording of their symptoms and their concerns and worries. And I'm very concerned that this is going to lead to this knock-on, serious things not being addressed fully because of this. Have you got any thoughts on that? It seems to be a particular generational thing. Thank you.
Yeah, that's a really helpful question, because you're right that many people will express concerns that if they give additional information to the receptionist, that the receptionist is going to be doing the triaging, and that's absolutely not the case. It does help to divert the inquiry through the triage process a little bit more efficiently if you can give information at the point, or some information at the point of seeking to book a contact. So we would encourage people to share a reasonable amount of information at that point, just to ensure that the process is as short as possible in getting them to the right destination. But if people don't want to share that information with a receptionist, that's absolutely fine. What will happen then is that a member of the clinical team will contact them and will then start that process of triage. It may slightly extend that process if that clinician has to then move the inquiry onto somebody else, rather than the receptionist being able to do that. But nonetheless, they will still get to the end place and don't have to tell a receptionist anything that they don't feel comfortable doing.
Thank you very much for that, Chris. Yes, I mean, I think varying systems within varying surgeries, I don't think it's a uniform approach from what I hear, but I'm sure that we're all eager to get back to as much face-to-face as possible. Thank you.
Thanks, Cheryl. Thanks, Chris. Thanks, Jill. So, and Teresa. So I'll close that item there, and thank you for the update that is very much welcome and received. So we'll then move on to consent items. Unless there are any objections, I intend to move 3 of these items on block. So the first I intend to move on block is the first, that's the section 12 doctors, wherein we're asked to ratify the attached list. The second is documents signed under the seal, which Louise has shared and asking us to note the list of documents. And the third is in terms of the charitable funds investment policy and its adoption of ethical principles. So are you happy to move those items on block under consent?
Yes.
Thank you. Anybody else?
Yes, happy.
Yes.
Okay, right. So that leaves the health and safety annual and quarter 4 report. Leslie, I think you've got Peter with you. I think we ought to provide an opportunity to discuss this report and receive any observations, given its nature and the extent and comprehensive nature of the information included therein. I've certainly got a couple of questions. But Leslie, Peter, shall we take it as read? But can I ask you to highlight any matters of particular note that you would want to recognise from the report?
Yeah, sure. Bore everyone. I think the main thing is obviously the volume of RIDDORs that has increased. Previous year we've had 105 previous RIDDORs, 2019 to 2020, and last year we had 820. Now, obviously that involved 745 that were COVID related, every one of those had a 72-hour review, a Make It Safe review, and an investigation. So the volume of work that has increased, we also did 48 health and safety reviews, 431 social distancing reviews of premises. That increase obviously just changed our whole health and safety priorities for the last year. We've had obviously some lessons learned undertaken from that year, whereby we pull together things like falls information and make sure that the falls group is operational and active. We are seen as a leader in reporting of RIDDORs. Our investigation and line list and process is seen by others as best practice. And obviously we're complying with the law when we're reporting these things. It has been incredibly challenging. And I think, as mentioned earlier, the variance and how we can, monitor staff movements and patient movements across wards and how we can, investigate those cases has been incredibly challenging. But, the work of the team and everybody involved has been pretty incredible, really, to make places as safe as possible. And I just wanted to kind of say that the team has done incredibly well, despite challenges we've had to deliver what we've delivered. The focus now goes, more on our general health and safety, our estates-related work, the asbestos, the Legionella, the fire, the electrical safety still go on. And we've also done, contributed to the field hospitals, both the commissioning and decommissioning, the security arrangements in place across the organisation over the last 12 months and 18 months. Has been, again, challenging, but we've kind of risen to that challenge as best we could as the team. Happy to take any particular questions about the report. I just wanted to give a brief overview because I recognise everybody would have read the report.
Thanks, Peter. First question from John.
Thanks, Mark. Thanks, Peter and Leslie. It was just a question really about the RIDDOR reporting from COVID point of view. Is there a sense that the volume of those reports is reducing now that we've got a better handle on handling COVID compared to the early days of the pandemic?
Yeah, I mean, what we saw in the early part of the pandemic was large amounts of clusters, and the actual health and safety guidance changed from likely to probable. So the actual guidance changed on RIDDOR by the HSE.
Right.
And obviously our genome sequencing information, our track and trace information, our roster management of staffing. When we do an investigation now, we involve all parts of the organisation. There was an awful lot of volume early on. We probably reported large numbers based on the information we had, but we are much better now and the much lower reports now. One every 2-3 weeks that we can identify as work related, as opposed to mass volumes early on. Yeah.
Okay. And do we have a sense that the better level of reporting for non-COVID ones will continue in that way going forward, do you think?
Yeah, I mean, we did see a decrease. Obviously, the 120 previous year, we only had 53 sort of, I would say, our normal RIDDORs, musculoskeletal disorders, slips, trips, falls. We're obviously focusing on making sure people are reporting those as well. But every time there is a COVID staff member, it's put on Datex, and that initiates our investigation.
Okay, thank you. Thank you both.
John, before you go, in the assurance report, your assurance report from the DRG committee, you highlight an issue, I think, around CCTV monitoring.
Yeah, CCTV was one of the two things. What was reported to us was a real problem between, we've got multiple different systems, no ownership of policy and no common management, that's leading to certain issues in terms of one aspect being of which it's impacting our ability to respond to health and safety issues.
Yeah. We recognise that, John, and obviously as part of our business case, we're looking at developing the security management system. This year, we've spent 250,000 on the security CCTV. Longer term, the ideal would be to have a central hub based in probably Glenclwyd, whereby we can monitor it centrally and manage it centrally. So there is plans to look at the whole CCTV system and integrate it rather than it being separately managed and even, you know, separately maintained by different companies. But that is part of the project that states are doing.
But I think within that we need some commonality of management now, don't we? Because there are other issues such as potential risk to not meeting our legal requirements under for information governance and things, and we're not able to respond properly to the police or other inquiries for information, for sort of crime prevention side of things as well. So it's, I understand if we've invested in multiple different systems and that we need to do something as a consolidation, rationalization to bring it all together. That's one aspect, but we still need to be able to wrap around one common policy and one common management approach, don't we, as soon as possible.
And the CCTV policy is in draft, going to the next strategic occupational health and safety group. So,
okay, do we know when that is?
It's August.
August, right? Okay, so fine. We'll see. We'll no doubt see that after.
Yeah, and the business cases are going forward 28th of July.
All right. Thanks very much.
Thanks, John. Thanks, Peter. Jackie, did you want to come in?
Yes, please, diolch, Mark. Pete, I just wanted to highlight in this public arena the commendable work that the health and safety team have been doing. They've been phenomenal over the last 18 months. And I think both Jan and Billy, in terms of trade unions, would want to pass on their thanks for the amount of partnership work they've done. So that was the first point. The second point is around the obligatory responses to violence in healthcare. And I think it might be worth updating the board on actually the progress that's been made in terms of offering training to managers. I think I've forgotten his title. Our manager in that area will has been doing a lot of work and gave a presentation for trade unions earlier this week, which I think we're rolling out to managers, which will be very helpful. So that was it. Thanks.
Dave Baker's our violence and aggression case manager, but he is working across the organisation and also working with the police on those responses to make sure that we learn lessons from security incidents and get better at managing that as well. Thanks, Jackie, for your support.
Okay, thanks both. Thanks, Peter. Lynn?
Thank you.
Hi, Lynn.
I'd like to support what Jackie's just said about the amazing work that your team have done. And if I could then just take you to the recommendations. There's a whole raft of very broad recommendations here covering every aspect of health and safety. Do you feel that you've got enough resources and capacity, including money, to be able to deliver on all of these recommendations?
Well, there is a number of business cases, Lynn, going through the system at the moment. We've already sort of delivered a couple of those that need modifying. All four of our business cases are going forward on the 28th of July. And we're obviously hoping that they will progress so that we can, deliver the appropriate service.
And do all those four business cases cover all these recommendations?
Pretty well, yeah. Yeah, security, manual handling, fit testing, immunisation and training.
Okay, so really we need to know the results of those business cases and ask the question after that day.
Yeah.
And in terms of manual handling, Lynn, we have identified premises to be able to take that piece of work forward, because one of the issues is that the premises that were in place pre-COVID are no longer available or not big enough and for social distancing, etc. So some external premises have been identified.
Yeah, that's changed a lot, Lynn. Actually, we used to be able to train 20 people for manual handling, and with COVID-safe environments, we're down to 6. So that directly influences our capacity to deliver the training.
Earlier on, John mentioned root cause analysis and non-COVID RIDDOR events, and I note that you were not very impressed with the way that these root cause analysis has been carried out. So is that an action you're looking at?
Yeah, a training program to make sure that there is consistency. What we're also doing is making sure that the HMTs and area teams are reporting back on lessons learned. So part of the strategic occupational health and safety group now, we're asking all HMTs and area teams to report on their safety performance, to give us an overview of what, what's being implemented, what policies and systems are in place. So that's starting to come together as well.
Okay.
It's collective ownership, isn't it?
Yes, and it is, and I noticed throughout the report, you know, we need to learn lessons, don't we?
Yeah, definitely. I think the problem is that sometimes we'll learn a lesson in one part of the organisation that's not transferred. So bringing those lessons to the strategic occupational health and safety group is where those lessons can be learned, and consistency of policy. So making sure the policies are being implemented through the health and safety reviews, we can look at it back on site.
And I'm sure that's something Lucy would wish to be reported to the QSE committee.
Yeah.
Okay, thank you, Peter. Thank you.
No problem.
Okay, so before I come to my questions, Lynn has highlighted a point, Peter and Leslie, that and Jill, that I communicated to Joe before this meeting. So I think, and I'll come back to this, the board can endorse the recommendations set out in the report that do not carry resource implications. We can't be asked to ensure certain staffing levels until we understand what the financial implications of those commitments are. Yeah, you refer to business cases. We'd expect the business cases to be received by the executive team, for them to take a view on them, approve them or not, and then for them to move forward to Finance and Performance Committee. So I just want to land that point now.
Yeah,
looking for
that's understood. Yeah.
Okay. Yeah. I'll come back to that in a moment. So
and just to support that, Mark, they have been discussed at the exec, and as Peter described, there is some nuancing taking place before they come back to the executive.
Okay, and can we just agree, as we would all now already, Jill, that they'll go to F&P after they've been to ET, the executive team? They'll go to Finance and Performance Committee.
Yeah, we can agree that. I'm sure Sue Hill, our finance director, will ensure that's on the agenda.
Okay, John, did you want to come in on that point? The hand's just gone up.
Yes, just a quick one. I'm not sure that I recall that they're on the business case tracker that we've seen. Just need to make sure it's on that as well, so we can track progress.
Yeah. Okay. You follow that up outside, John, please.
I will do.
Yeah. Okay. All right. So some observations, questions from me, Peter. So good to see that staff injuries have fallen, but 57 seems far too many to me. You've alluded to some of the actions around that, but presumably you are focused with colleagues on that particular topic, along with the wider violence and aggression that you note in the report, Peter.
Yeah, absolutely. Obviously, part of the musculoskeletal injuries are potentially as a result of the manual handling issues identified. So additional training and making sure that our training processes are in place.
Right.
Slip, trip, falls group established, looking at training policy and risk assessment process for that. So yeah, we identify our themes, and that then goes into our strategic objectives for the team. And we're looking at how we measure that. For example, questionnaires from the manual handling training. Can you implement the training back in the workplace? We'll then track that through the system. And if people are saying we can't implement this because we haven't got the right equipment, we can then follow that up in the workplace and make sure there's right equipment, right training. And that's the piece of work we need to focus on now, really, is that we implement whatever measures we put in place. What is the outcome? What is the safety outcome of implementing that system? And that's a part of work that we'll be doing over the next 12 months.
Okay, that's helpful. Thank you. Bottom of page 5, Peter, in terms of clusters, there's reference in the bullet points, the shortage of PPE in work areas. Jill, tell me if I'm wrong, but I don't believe the health board ever ran out of PPE at a corporate level. So is that point, Peter, concerned with the distribution of the PPP we have to work areas?
Previously, I think there were at times during the last year where there was a struggle to get the right PPE and to be fit tested. So making sure all the staff were appropriately fit tested to that PPE was a challenge. Jill, did you want to come in?
Yeah, I think the point was that the FFP3 masks were being suppliers were being changed at short notice. So it wasn't about necessarily the supply, it was our ability to train staff, because every time we change a supplier, we have to retrain staff. So there was a point during the pandemic where there was quite a focus on having to retrain staff. We've now introduced a mechanism whereby staff hold a card, that's correct, isn't it, Peter?
Yeah.
And it identifies all the FFP3 masks that they have been trained on. So we're clear about that they are receiving the appropriate equipment for their training. But that was an issue at a point last year.
Yeah.
All right, okay. Thanks both for the explanation. Peter, I'm going to take you to page 8. Annual breakdown of patient-related incidents reported under RIDDOR. 18 listed. It refers to the investigations being carried out or carried out. Are there any trends, Peter, from those investigations that we ought to be aware of?
I think the main issue would have been falls. Falls of patients and risk assessment. That is a trend that we are obviously following up through the falls group, but that's the key issue that we're addressing.
Okay, thank you. Leslie, you and I had an exchange about 5.1 and 5.2 being out of date in terms of content. I understand why, because these reports have flowed through committees to get here. You've provided an update. Can I ask that you share that with board members, please?
Yes, happily, yeah.
Thank you. And then, Peter, final one for me in terms of specifics. Bottom of page 11, needle, stick and sharps injuries. Comparative figures. Central is by far the highest site last year for those types of injuries. Do we know why?
Occupational health will be looking into that. I can get back to you and describe why that is offline.
Okay.
I do not know at the moment.
Okay.
Why it was so much higher.
Can I ask you to feed that through Jill to me then?
Yeah, sure. Absolutely.
You happy with that, Jill?
No problem.
Okay, thank you. So returning to what I said earlier on, I think at the moment we'll say that we note this report, Peter and Leslie. We support the recommendations that don't carry a resource implication.
Yeah.
And we'll look forward to receiving further information about those through business cases after the executive team have considered them. Does that sound okay to you?
Yeah.
That's absolutely fine, thank you.
Okay, and can I thank you, Peter and team, as Jackie highlighted earlier on, for all the work that's going on in this area. You've certainly brought some focus to what is clearly an important statutory area of business for the health board and the organisation. So thank you for that. And thanks to you, Leslie.
Thank you.
Okay, so I will close that item there, and we move now on to items for discussion. And the first is associated with targeted improvement. Jill, are you taking this in Joe's absence?
I am happy to, Mark, and obviously there's a Chair's Assurance report that directly follows this about the work that we've been doing around targeted improvement, as we would like to call it, but is targeted intervention. So this does describe, I'm not going to go through the paper in detail, assume people have read it, but it does describe the progress to date, and happy for myself and any of the leads to take any questions. It should be noted that we've since had another meeting of the task and finish task and finish group around the targeted intervention steering group. That has happened just this week, and we've also starting to implement the wider governance around the evidence and effectiveness groups.
Okay, thanks, Jill. So I'll take the first item first. So in terms of the framework, are there any questions on the framework update? No, I can't see any hands raised. Jill, I had one. If you go to page 3 of the report, first paragraph, at the end it notes.
Implement the wider governance.
No, it refers to gap analysis is also planned to identify any attributes within the matrices that require but do not have any actions attached. I would have thought we would have done that by now. We're formulating the responses to the 4 domains, or am I misreading that? You see it, Jill?
So on the top of page 3.
Yes, this last sentence, gap analysis is also planned to identify any attributes within the matrices that require but do not have any actions attached.
Yeah, so Simon is on video. So before I answer, I'm sure Simon's got an answer on that.
Okay.
Yeah, sorry, Mark. That's an ongoing piece of work, because what we want to make sure is that any actions that are identified as we move through the matrices are also included and linked into the annual planning process and are in there, so that we don't end up with 2 sets of plans taking us in different directions.
So just to confirm then, at this moment in time, we think we've got actions in place addressing all aspects of the 4 matrices.
Yeah, absolutely. But there are things on the in the matrices that aren't in the annual plan, but we know that we're doing. So the board development program isn't in the annual plan, but is linked, is a piece of work linked to the matrices. So we just want to make sure that everything is aligned as far as possible, so that we don't have two sets of plans to go and view. It's just trying to make this as business as usual as possible, rather than a separate program.
And just to support that, Mark, if I may, we also had discussion at executives yesterday around the structured assessment and ensuring again that we're cross-referencing evidence everywhere, so that it does become business as usual. It's the way we do things.
Okay, all right, thank you. So that was my question. You've answered it. Thanks. We'll go on to the second item. So are any questions associated with the Chair's assurance report in respect of the targeted intervention framework? Right, I can't see any. So Jill, thanks for both those documents. Simon, thanks for the clarity. We were due to receive the YG Outbreak external review report. I have withdrawn that item, having spoken to Joe, because I don't believe the review report addresses the terms of reference set for the review, and therefore Jill has taken that away to discuss further with the reviewer, then report back. Is that right, Jill?
It is, and that action's been I have already contacted the reviewer.
Okay, and you'll keep us updated?
Of course.
Thank you. Thanks. Okay, so we move on to vascular.
Can I just make one point, Mark, if I may?
Yeah.
And that is just to give some assurance to the board, recognising it's not full assurance to the board, but during the review, there were no immediate actions requested from the team. So there were no immediate actions of concern following as the review was taking place. I just think it's worth saying that.
Yeah, okay, thank you. That is noted. Thanks, Jill. So we'll move on then to vascular task and finish group update. Arpan, there is a report. There are a variety of appendices I know that were shared for information of board members. But should we stick to the report? You ready, Arpan?
I am, Chair. Sorry, you froze on my screen, so apologies for that. Yes, thank you. So this report and the attachments that are in your packs is to provide an update to the board on the state of the vascular surgical service in general, and also the programme of work which is underpinning the improvement plan following the RCS review of the service earlier in the year. As you will note in the report, following the receipt of the RCS review, there's been a process of reviewing and refreshing the structure and function of the task and finish group as it was previously known, and we have carried out that work already with the help of colleagues from the CHC. This has now taken the form of a steering group with a number of task and finish groups feeding into it, and this essentially now represents the very large body of system-wide work that we now appreciate is required to address the improvements in a sustainable form. We have undertaken some real in-depth internal reviews, and it has become quite apparent that for sustained benefit from the service for the patients of North Wales, it's important to examine not just the service itself, but also the adjacencies and the interdependencies that impact upon the vascular service itself. A clear example of this, of course, is the diabetic foot pathway, for instance, because any issues, for instance, which cause problems for patients in reviewing diabetes care and the foot care, for instance, in primary and community care, will eventually impact on how they present into secondary care to the vascular service, and this will, of course, impact on outcome. So just to illustrate that point, I would like to refer to some key areas in the update as I go along, but it may be helpful to members to note Appendix 1, which describes the hub and spokes model and the availability of the services currently in our 3 acute hospital sites. Because one of the key recommendations, of course, has been to recognize the service provision and strengthen the provision of the services in the spoke sites. If I focus in on the diabetic foot pathway, as I've stated previously, and is being recognized widely, it is not a vascular service pathway, but it is indeed a reflection of diabetes care and the pathway that supports that service. Indeed, vascular services, of course, has a very key role to play, as does orthopedic surgery. And some of the work that has gone on in the background successfully, particularly across secondary care, actually reflects the very obvious representation of orthopedic services into that foot care process that I'm happy to sort of elaborate on if members need that clarification. But certainly there has been a significant progress across the 3 hospital sites on this matter. And at the end of this week, I hope to further solidify and crystallize the pathway, both in the primary community care setting, as well as in the secondary care setting. There's been comments made, obviously, in the RCS review on pathways and the bed base present in the spoke sites. Now, one of the points to state here is, of course, that bed capacity is very much dependent on the clinical pathways that emerge, and obviously clinical thinking has progressed and has changed since 2013, where some of the original thinking and decision making was derived from. So clearly we are in 2021, and although a lot of the clinical thinking and evidence has moved along, I think it is important to state that both the Royal College of Surgeons, as well as some of the more recent reviews across the UK NHS, and I'll make reference to the vascular Getting It First pathways, these programs still absolutely support our current model, which of course needs strengthening. There is a need for some discussions in terms of the configuration of the bed base across the 3 DG8 sites, and that will require some discussions based on recent clinical evidence, because much of that work at the moment is really about changing some embedded cultures and some embedded ways of practicing and looking after patients. That process is currently underway and will be continuing in the forthcoming weeks. One of the other key areas which has been the focus of attention, has been the optimal use of the hybrid theatre in Ysbyddyg Glenclwyd, and obviously where the major arterial work has been centralised. It is quite clear that the service model will need strengthening in the central site because of the increased demands on the service for more complex work that is undertaken in that sphere, and a number of spot audits of capacity and demand have already taken place. There are pathways that have been agreed in terms of how the hybrid theatre can be utilised in a more efficient and effective manner, and some of the documents included in the pack will show the evidence in terms of the standard operating procedures that have now been agreed. Clearly, there's a large impact in terms of how that scheduling will affect current consultant job plans, and there is a further adjacent piece of work underway in terms of examining the job plans and may require further expansion in terms of consultants and other grades that we may need to include in the service going forwards. That brings me on to the subject of consultant presence, which is an important aspect of strengthening the service in the spoke sites as well. So to assure board members, of course, that specialist vascular service input is available to the spoke sites 24/7. However, we have examined what it would take to have a consultant presence, at least on regular working days of the week, and that has revealed some gaps which are being worked through once again in terms of job planning. But certainly some innovation has been put in. So in the last couple of weeks, it was possible to have consultants present on all the spoke sites for most of the days, apart from one day when there was some sickness. So there is a detailed job plan review as well. We absolutely acknowledge that there is a need to communicate to our patients and users what the service actually provides, because sometimes that is also a little bit unclear. So last week, the Executive Director of Workforce and myself met with the communications team to agree principles of communication going forwards, which will consist of a refreshing of the current website to make sure that patients across North Wales and carers become much more aware of colleagues who are providing that service in the greater clinical team sense, and also the kinds of services that are available. It's very encouraging that we also have a number of patients who have benefited from the service who are keen to come forward and share some of their patient stories. So I'll stop there and take any questions or clarifications.
Okay, before I open it up, I'm conscious of the fact this was discussed extensively at the QSC Committee, Quality and Safety Committee, albeit Lucy, the chair, is not here. I believe Lynn was present. She's got her hand up anyway. Lynn, did you want to give any feedback from QSC Committee before we come on to any questions we might have as a board more broadly?
Yes, thank you. That's why I put my hand up. Thank you, Mark. We were very fortunate at the last few QSE meetings, and especially at the last one, is that we had the time to forensically go through every single one of these appendix, and we asked questions and we delved very deep, and we did put ARPAN on the spot on a number of issues. ARPAN's covered a lot of the things that need to be done. Our concerns were, how had we got to this place? And what could be learned to avoid this happening again? ARPAN did explain, and we were satisfied, but this is an area that's got to be constantly monitored. A lot of our questions were centered around what happened since the original decision in 2013. We talked about the beds, we talked about the hybrid theatre, and we also spent a lot of time on understanding what had been referred from the spoke to the hub and vice versa. and we were pleased with the work that had been done to try and sort those pathways out. Although it has to be stressed, we were extremely disappointed that we had assumed a lot of these pathways were in place. We were also happy and pleased to see it written down what was being offered on the 3 main sites, and that did give us a lot of assurance. So we need to thank you for that. So it was a very, very good, detailed, lengthy discussion, which we did receive the assurances and the reassurances we required. But it is an area that we will continually monitor. So thank you, Arpan, and I think you've done a good presentation of what we discussed. So thank you.
Thank you, Lynn.
Thanks, Lynn. Just on that first point, so Joe and I have had an exchange out with this meeting, but before we got here, and following QSC committee meeting, Arpan, Joe and I are agreed we need to do a look back at some point in terms of this service change and what we could learn from this service change, so as to learn the lessons for the future in terms of any other service change that we will undoubtedly be minded to do at some point. Could you, bear in mind Joe's not here, Arpan, could you pick that conversation up with Jill and Joe after this meeting, please?
Most certainly, Chair, and I would absolutely acknowledge and strongly agree with that statement. It's a large, complex organisation, and there is learning going on every week. So even after, let's say, the QSC presentation, just as an example, Chris Stockport very kindly flagged up a few issues which I have now addressed, and it's I think there is a lot of learning personally for me in terms of actually listening. In terms of what is happening across the organisation, which is large and complex, and not just rely on a single source. And I think that to me is one of the crucial things, how we actually create that sort of network learning when we consider further changes to our service provision. But I would.
Thank you. Jill, did you want to come in?
Yeah, just to say that Joe has already mentioned that to me, so Arpan and I and Joe will pick up outside. Second point to make, that in the paper it refers to the vascular network manager. I understand those interviews are this afternoon, and we're confident we'll be able to make an appointment. And the third thing, you'll understand that Clive Walsh has just joined us in replacement for Gavin in a slightly different role. I have asked him to support this piece of work as well, so we've got that senior oversight.
Okay, thanks, Clive. John, did you want to come in?
Yes, please, Mark. I've just got a couple of quick questions. First one's a point of accuracy, maybe on Appendix 1. It's good to see that description, and I know Lynn touched on it in terms of what happened, what was happening at what point. But while we were running that interim 2-site model, 2015 to 2019, what you've got in the document, Arpan, is that we were doing all major and minor vascular procedures on YGC as well. But if we were running the 2-site model, that was happening in Ysbyty Gwynedd and Wrexham. Is that accurate, or am I misunderstanding that?
Sorry, John, can I just clarify which part we are talking about? Is it the 2015-19 2-site model, the column in the middle?
In Appendix 1, the section around YGC. We were obviously running the 2-site model as an interim position until we moved to the
okay.
model.
Yeah, I see what you mean. Can I clarify that further with the service and come back to you?
Yeah, please. Okay.
Yeah, thank you.
And then the second one was one of the other attachments. It talked about the one around outpatient joint podiatry clinics at YG. And on page 2, there's a reference about the vascular budget, which is no longer agreed. And it just raised a little flag of concern for me. What does that statement mean in terms of the budget's no longer agreed?
I think there's been some conversation in terms of resources and where they derive from, because clearly once the vascular service was established, there was an increase in terms of the podiatry requirement. So I think that reflects a certain lack of clarity that we are trying to sort of delve into in terms of was the podiatry service also included in that expansion. That's my understanding. But once again, I will further delve into that.
Okay, thanks, Arpan. Thanks, Mark.
Thank you.
Okay, thanks both. So we'll therefore receive the update as recommended, Arpan. Thanks for that update and also for the exchange at QSE. Just to confirm, Arpan, we'd expect another update at the next board meeting by QSE again, please.
Indeed. Thank you.
Thank you. Okay, so I'll move on from that item onto urgent care improvement. Jill.
Thank you, Chairman. And can I introduce Chris Suby, who has recently been appointed as our clinical lead for unscheduled care across the health board. Very early days for you, Chris, but it's really good to have you here. I'm asking the board to receive the paper, and I'm sure that colleagues have read it. There are a couple of points I'd like to call out, if I may, Mark, before opening it up to questions. So what I want to call out is that all our ED departments are seeing extreme pressure. This has been exacerbated by a number of things, including the requirement to test patients coming into our organisation, trying to manage red and green pathways, a reduction in beds as a result of the requirements around social distancing. And then, as I described earlier in the COVID report, that we are actually not seeing the access to care home beds that we've historically had. And again, that has been impacted, as was called out earlier by Linda, by an increase in tourism in North Wales, way beyond what we've experienced previously. And clearly these are also accessing our emergency services. There are other points I want to pull out, and that is that we are seeing people that have perhaps not stepped forward during the pandemic that are now presenting our unscheduled care services. This is not unique to North Wales, but we are certainly feeling the pressure. And as a consequence of that, we have had expressions of a concern raised by our ED clinicians, who are really, really feeling this at the moment, where we've got significant numbers of patients being waiting in our ED departments because of all the reasons that I have explained. Now, as a consequence of a meeting, a chair you and I had, and even before that, we met with some ED clinicians, and we have commenced an improvement programme. That is not a magic bullet, as I'm sure Chris is going to say, but there is a number of actions that are now taking place. We have been able to resource that programme. As I say, Chris is now the clinical lead on that. We are starting to resource the support for him that sits around that, including analytical support, so that we can see the areas that most need help or best opportunities. And a lot of this is also about how we manage our public and public expectations of how they can manage themselves without resorting to our ED departments. We have met again with the ED consultant lead in Ysbyty Gwynedd, and absolutely recognise the pressures that all our staff are working under at the moment. We do have locality plans that are owned by the localities. When I say locality, that will be our east, west and centre teams working in partnership across the community and the hospitals. And those are beginning to not only formulate, but we're beginning to start to pin down the actions and the outcome expectations of those plans. I'm going to hand you over to Chris, if I may, to just describe the work that he has been undertaken in the short time he's been with us, but your impact, I know, is being felt, Chris, so thank you for joining us.
Good morning. Yeah, just to say, my name is Chris Subi. I'm a consultant in acute respiratory and critical care medicine and a senior clinical lecturer at Bangor University. Most people in this clinical sphere will know me from the work that we've done around deteriorating patients when we created pathways and tools to reduce rate of cardiac arrests across North Wales by about 80% across the 3 hospital sites, and when we developed the National Early Warning Score and the tools that have spread from North Wales back into the UK and around the globe. This is an extremely difficult area, and I started on the 5th, so exactly 10 days ago, with my involvement in this program. So what myself and the project manager and the team around us is trying to do at the moment is to get a better handle on the data, see where we think that the early wins might be, and with lots of staff on all 3 sites. And so I spent a whole day in Wrexham yesterday, I spent a whole day in Glenclwyd the day before, and I'm continuously talking at the moment to particularly clinical leads who will have to deliver on some of this. So the first month is around metrics and engagement, and we hope that at the end of this month we'll be able to have programs that we can share and then start to realize. You've seen in the paper that there are themes that have been identified already, and we're focusing on delivering those and underpinning them with the metric that will drive them. And one of the things that I've been very clear on when I started is that we need to have a metric that is understood by everybody. That's the public, that's the clinician, and that's my managerial colleagues. And we will be very open about what this metric is and how we will track this. But this will take a bit of time so that we really got buy-in to do this. I'm not sure what more details I should add at the moment, but maybe questions might be a way to address concerns or questions that are in the participating people on the call.
Thanks, Chris, and welcome to your first board meeting. I've got a question from John first. John?
Thanks, Mark. Welcome, Chris. Couple of points from the paper. One, on page 3, there's a graph included. And apart from the obvious outlier around COVID, around March, April, May, whatever it is, there doesn't seem to be a clear correlation between attendances and actually the performance. So what struck me was, is there something more fundamental underlying our overall performance in ED that's not actually to do with attendances or ambulance handovers, and that we need to address that patient flow in a different way?
I think I think you're right. These graphs don't give us really an explanation of what is happening and why it is happening, and I think that's one of the pieces of work that we're undertaking at the moment. On the whole, I think they're pretty flat. There isn't much in terms of change, and this is a complex adaptive system. And I think what you really picked out is that this is not a linear system. So you move one parameter, all other parameters will move in a predictable way. This is a complex adaptive system. So when you start to move one parameter, all parameters might move in different directions. And that's the reason why I think we need to have agreement within the clinical teams which ones of those things we really think is the one that tells us what patient experience, patient outcome is. And dare I say it, staff experience, which has been exceptionally challenging over the last few months. And this graph at the moment, unfortunately, doesn't give us this analysis. And I think you absolutely, I agree with you.
Okay, thanks. I think that goes to the second question then, to me, which is further on in the paper, bottom of page 5, around the improvement programme. It talks about reducing harm, improving patient outcomes, but it just struck me as being too generic.
Mm-hmm.
Can we be more specific about what outcomes we're being aiming at, about setting expectations? That's going to help drive better improvement, isn't it?
Yeah, absolutely. So, you know, in both the interview and all the conferences that I've had in the 10 days since I started, for the first month, we will tell you the process. We're consulting with everybody that we can get our hands on, and we will then define publicly what outcomes we're focusing on, and they will be trackable. And they will be trackable for anybody who wants to track them. At this moment in time, we haven't agreed those with clinical leads, and I think it would be uncautious to do this in this forum.
No, I accept that, but if keeping us advised that that is the aim to do that, I think helps in terms of assurance for us in terms of
absolutely.
And just to support Chris on that, John, I think all of the work we're doing now in determining what those metrics are and what the outcomes are, because this isn't a target, it's a standard. It's a standard we should be applying to the people that are using our services. We serve the public. We shouldn't forget that. And actually, we need to be really clear on what they are and the reporting framework behind those. So, you will see changes in the reporting papers that you've historically received around unscheduled care through to board subcommittees as a consequence of that. So we're making it explicit. I think the other point I would say is the numbers are absolutely right. They're not the whole story. As I said, we've lost beds across the system. We know that, and we're having to manage in a very different way. And that's having an impact as well. But all of that comes under the analysis that Chris is doing, which is why he is being supported by full-time analytics, which is a different way of managing this moving forward. And I think being very well received by Chris and the team.
All right, thanks, Jill. Thanks very much, Chris. Back to you, Mark.
Thanks, John. Jackie, next.
Thank you. Hi, Chris. I suppose I'm not sure whether to describe myself as fortunate or unfortunate in that I get to attend the daily huddle, particularly in Ysbyty Gwynedd. So I've seen the challenges that our medically fit for discharge patients present to the team in terms of flow. What I really wanted was some assurance or reassurance that diagnostics are fully involved in this process. As we all know that timely access to imaging in particular aids the flow that we have of our patients through the hospital. So I just wanted some assurance around that, please.
I think this is a whole system design a project, and as I said before, Jackie, the problem is that all these parts hang together, they interact with each other. So you're absolutely right. If I haven't got access for patients to timely imaging, I can't establish a diagnosis, I can't start the right treatment, I can't predict the rate of recovery, I can't communicate to the patient when they're likely to be able to return to their own home. So that's absolutely part of the process, and thanks for raising it.
And again, just to add, Jackie, we had a conversation yesterday at the executive team about planned care and diagnostic element of planned care, and the challenge was put back, well, how do we resource diagnostic for unscheduled care as well, because the one absolutely impacts on the other. So the challenge was sent back to the diagnostic team to bring those two pieces together, because completely cognizant of what you've just described.
Okay, thank you. Nikki.
Hi, Chris. So I want to commend the data analytics approach and also the systems approach to this. I think it's absolutely fabulous. But the common thread that runs through this is the patient. So I just wondered, in terms of that patient experience, is sort of the qualitative piece going to come into this to help inform service improvement?
Thank you for raising that question. I can only partially answer that question at the moment. What we're really pushing for at the moment is in the value-based healthcare framework to have patient-related outcome measures. For unscheduled care so far, there are no patient-related outcome measures. We only got some very incomplete questionnaires that capture some of the experiences. Now, at the moment, they tell us what we can see if we just go to the front of the hospital. The experience is not the way we want it to be. I will give a supplementary answer to this. I'm National Lead for Quality Improvement for the Society for Acute Medicine, and we have over the last couple of months agreed priorities for the society, for the UK wide body of acute physicians for improvement. And those, you'll be delighted to hear, are of same-day emergency care. How is that done well? What's the metric that underpins it, and how is it done? And we are commissioning specific training for this. And as a second workflow, we have agreed to develop patient-related outcome measures for unscheduled care. We're doing this internationally. We've got some Dutch PhDs already done significant work on this, so that we hope that later on this year we'll be able to be in a position that we can start testing some of those in a UK setting. So I will be able to give you a good answer to that next year, but not this year.
Excellent, thank you.
Okay, thank you. So, Jill, just coming back to the conversation you referred to yesterday that you, Joe, and I had with Nikki, the clinical lead for emergency department at Ysbyty Gwynedd. I think we all come away thinking we know of the concern that exists. Of course, you know, you and I have met with 3 clinical leads previously, but they obviously want some sense of greater recognition that we are working to resolve the challenges that they face, and I guess they want some sort of sense of immediate assistance. The longer term program will take some time. I think though, Jill, I'm sort of take away the business case yesterday, check where it was to see if there are any interim solutions that we can offer to Nikki and the team. Could you just confirm?
So yes. Sorry, Chair. Sorry for talking over you. Yes, I can confirm that I've made contact around the business case. There was a meeting yesterday, yesterday morning. There are some slight amendments to that, and I have been advised that I'll have that Monday. I'm also planning, I think Nikki is on leave next week, Chairman, but I have dates in the diary for myself, and I'm sure Chris will be there in Ysbyty Gwynedd to walk the floor and see what the immediate opportunities are. So yes, that is being taken forward alongside some of the recognition of walking the floor is also looking at what alterations we could make environmentally. But I would like to reaffirm, Chair, that we will be looking at this across the whole of North Wales. Yeah. So this will include Ysbyty Clan Clwyd and Ysbyty Maelor.
Okay, thanks, Jill. Chris, final word from you.
Yeah, I could just add to this, you know, outside of this particular role that I'm talking to about today, I'm obviously also an acute physician working at the Ysbyty Gwynedd. We've got some projects that we're starting in the next week that will hopefully help to release some of this pressure, which to a degree is driven by medical emergency admissions. So, you know, I'm hoping to be able to report certainly by mid-August whether those are having effects or not.
That would be helpful. Thank you. So in terms of this particular item, we are asked to note the concerns raised by the emergency department clinical leads, and that was repeated yesterday in a meeting with Nikki at Ysbyty Gwynedd, and to receive an update on urgent and emergency care improvement and the programme of work. Are members happy to do so?
Yes.
Yeah.
Okay, thank you. Yeah. So Jill, can we agree outside when we'll get the next update, please?
Yes, we can, and I'll agree that with Chris as well. So it's a meaningful update, Chairman.
I'm sure it would have been meaningful anyway, Jill. Okay, thank you. Be up and out. So, okay, we are at a comfort break time. So it is 11:15. Can I ask that colleagues dial back in at 25 past? We've got 10 minutes, please. Thank you. Okay, it is 25 minutes past 11, and I would like to start the meeting again, please. Mark, are you there? The next item is the quality and performance report. You are.
Yes, I am. Thank you very much, Mark Baradar. Good morning, everyone. So I'm going to present the performance report of the Health Board. It summarises our performance up to the end of May this year. I'm going to open up this item and then I'll ask colleagues to contribute as appropriate. Welsh Government performance management of us as a health board remains suspended because of the uncertainties created by the pandemic, and that limits our access to comparative information to fully understand our performance at present. Nonetheless, the report highlights areas where we are performing relatively well, and I would like to highlight those as well. The immunisation of children, healthcare associated infection, performance against a suspected cancer pathway tends to be strong, and that has continued to be an area of relatively good performance for us. I'd like to highlight radiology as well. We've seen a month-on-month consistent reduction in the number of people waiting over 8 weeks for a diagnostic test. And the executive team yesterday were committed to additional non-recurrent investment using the monies that we've secured from Welsh Government to improve access, and that should see us without any over 8 week waiters by the end of March 22. So that's all really positive. I think in terms of areas where we are less strong, we've just had a big discussion around unscheduled care, so I'm not going to dwell on that anymore, but clearly the report presents, I think, some of the challenges that we currently face around unscheduled care. I think the report also highlights CAMS and neurodevelopment, where our performance is less strong, and we may wish to pick that up in the discussion. That is an area and a priority for investment that we've recognised in our plan. We will also be looking to sign off later on this on this agenda. So we've set aside some resources now within the plan. We've got some clear commitments, but we now need to move towards full implementation in those areas. So I think those are the opening comments I wish to make, Mark. I'm happy to take any questions, as I'm sure are my colleagues as well. Thank you very much.
Thanks, Mark. Okay, so I'll open it up to questions. Any questions on the report? I can't see any questions, Mark, which is unusual for this item. Okay, so
Sorry, Chair. Is it worth noting that this report has gone through several committees, so many of the questions will have been picked up in the local committees?
it is, yeah. Thank you for that, Jill. Cheryl, were you just trying to come in?
Yes, Chair, thank you very much. Just to mention the CAMS and children's performance, this had a very thorough going at QSC committee, continues to obviously disappoint very much, but I'm confident that the measures we're currently getting into place are going to see a really good improvement in this. We can only hope, because it just isn't good enough. Thank you very much, Chair.
Okay, Lucy. Thanks, Cheryl. Lucy.
Thank you, Chair. We did discuss in QSE committee that there was reference made to the primary care access indicators, but there was no actual information within the document about these. But I note as well, we still don't have any primary care indicators in here. Can you give us a timescale, please, on when this is going to be addressed? Because it's an area that we are receiving a lot of scrutiny and questions on at the moment.
Okay, thank you, Lucy. So you're aware of the timescales for the work that we're doing to redevelop the broader IQPR report, but I think within those timescales, there is an opportunity to include some primary care indicators. I'd like to commit to those being included in this report to some extent, starting with the next board meeting, because we do have those indicators and we should be able to include them. I'm happy to give that commitment to the board.
Thanks, Mark. If we've got them, why have we not been reporting on them?
So our reporting tends to focus on the those indicators that we are held to account for by the Welsh Government. So we tend to focus on those, but I think we do have lots and lots of data. Clearly only a subset of that is ever reported through to the board and committees, but I accept the point you're making, and we should be able to include that in a future report. I think we need to do some work as an executive team to work out the indicators that are most meaningful and the most aligned to the strategic objectives that we've got around primary care. But it's very hard to, but you know, clearly we do have some indicators, and it's hard to defend no reference at all to primary care in this report. It's a commitment that I'd like to offer.
Thanks, Mark. I appreciate that, because as I said, we are getting a lot of scrutiny in that area at the moment, so thank you.
Thanks, Lucy. And Mark, we discussed that ourselves, didn't we, last week in our catch-up? That was my expectation too, which I know you agreed to respond to. Okay. Gareth, next, please.
Good morning. Thank you, Chair. I wanted to ask a question actually about unscheduled care. It felt more relevant to ask it against performance rather against the previous item. I'm aware, I think as many people are, that the minor injury units in North Wales have had a slightly more unstable year really with COVID in terms of their ability to open and support unscheduled care across the region. I wondered whether there'd been any analysis of impact of the closures of MIUs actually on our ED performance, whether numbers were perhaps small and therefore didn't impact on our performance, or whether the numbers over the year or so have actually caused our performance to reduce.
So I can comment on that a little bit. Jill or Chris may be able to add a bit more. Gareth, thank you for your question. So we have had a whole series of temporary closures, I think predominantly around our MIUs in the west, Dolgellau, and in other places in the west as well. They are temporary closures, predominantly related to staffing issues we've faced, and conscious decisions to redeploy resources to areas of greatest need. I can see that Jill's come in as well, so I don't know if Jill or Chris are able to pick up the analysis. Point.
So in terms of the analysis, Gareth, that's the question that Chris talked about, the analysis that we're doing as a team to look at the impacts in various places, and that is part and parcel of it. It's also part of conversation we're having about skill mix to support in different ways. So yes, Gareth, it is being picked up.
Gareth, not very much more to comment upon than Jill has just mentioned, other than just to reference the fact that as well as looking about the impact into secondary care, we are looking at the impact upon those individual teams that are delivering MIUs, and what do we need to go forward to make that a more stable offering. As you're aware, some of our MIUs are quite small, and it may be that there is only one advanced practitioner within the team on any particular shift, and in that environment, COVID and the implications of COVID have had far more of an impact than you would otherwise imagine, because of the difficulties in cross-covering and some of the difficulties of keeping red and green separate in small community hospitals. So we've reflected upon and are reflecting upon what the impact of COVID has in terms of how we can stabilise MIUs going forward.
Okay, thanks everyone. John?
Thanks, Mark. At the risk of repeating myself from F&P, I thought it might be worth just highlighting a couple of the positives that are there in terms of the improvement in stroke and the reduction in the RTT number. And I did ask at F&P about whether the fall in the performance of the follow-up, so the increase in numbers of follow-up appointments, is linked to that improvement in RTT.
Sorry, John, can you just repeat that question, please?
We've improved the number of patients for referral treatment in terms of the numbers reduced.
Yeah.
is it a consequential increase that we've seen in the follow-up appointment number, because that's gone up?
Right, okay. So I think it's hard to be definitive. Clearly, if people have moved through our outpatient system, they may move into the follow-up waiting list. So that is one explanation of that. But in terms of the shape of the curve, I think it's difficult to be that specific about, you know, which kind of cohorts and timings and things like that.
Okay.
I think the other discussion we had at FMP was about whether validation had made some impact as well, and we have done some validation off the waiting list, which I think has knocked a few thousand people off. We have seen a genuine increase in our ability to restart planned care. And on some information I saw yesterday, we're delivering between about 70 and 80% now what we're delivering in a pre-pandemic period. So we have seen a significant recommencement of primary care, planned care, sorry.
Okay, thank you. And the other one, because Jill referenced, you know, that we're becoming seeing more tourists in North Wales because we're becoming more of a destination. How much of our drop in ED performance is linked to that increase in tourists?
That's a difficult question to answer. I think we need to go away and have a look at that. I think that if we looked at ED and MIU attendances, we have seen a marked increase, certainly since the depths of winter. It's not gone up a tremendous amount over the last few weeks. Not sure about the connection between tourists and people being admitted into our hospitals. I think there's a very strong connection between tourists and attendances at our ED and MIUs. Hopefully most of those individuals don't end up needing to be admitted, but I think that is something we'd need to go away and have a look at that. I'm not sure if you've got any more information on that, Jill.
I haven't got any more information, but it is something that I've asked for some work to be undertaken on, particularly given the fact that we are about to move into the highest level of tourist season when the schools break up, and we're seeing the changes in the lockdown rules.
Okay. So I think you want to come in.
Diolch yn fawr, if I may. In preparation for this morning's the meeting that Lucy and I attended, I asked a specific question about the number of inpatients who are registered to an English address, and as of the midnight count, it was 41 inpatients across all of our hospital sites. So in combination with the number of the reduced bed availability because of social distancing and so on, not an insignificant number, bearing in mind delayed transfers of care and so on, John. And each ICU does have COVID patients in at the moment, no breakdown on postcode for ICU.
Okay, we also get tourists from South Wales as well, don't we? So that would
I can tell you outside.
Yes.
I'll let you know where people have come from. It is mainly the northwest.
Right. Okay. Thank you. Thanks, Mark, as well, and Jill.
Okay, Linda, I think you've got a question.
Diolch, Mr Cadeirydd. A mae o'n dilyn ymlaen o cwestiwn John i dweud y gwir ac yn perthyn i'r cwestiwn nes I gofyn yn cynharach. Dwi yn gael eisiau pryder am y ffaith bod yr ysbyty cymunedol yn Nolgella ar gau ar hyn o bryd, a dwi'n deall bod o dros dro, ond mae hyn yn wedig ar ôl y sgwrs da ni newydd cael ynglyn â'r nifer o ymwelwyr sydd yn yr ardal ar hyn o bryd. Mae o'n codi pryder arna i, achos does na'r un uned agos i ysbyty Dolgella, a dwi'n siŵr bod yna ysbytau cymunedol eraill yng Ngogledd Cymru yn yr un sefyllfa. A dwi'n deall mae prinder staff yn gallu creu problemau, ond gai ofyn am ymrwymiad, os mae hyn yn broblem, hynny yw prinder staff, bod hyn yn cael ei edrych yn blaenoriaeth, bod yr unedau mae ddim yn cael dros dro, achos mae hyn yn codi pryder arna i ynglyn â'r gwasanaeth. Da ni'n gallu cynnig i bobl ar diffyg gwasanaeth, mi fyddwn ni felly yn gallu cynnig mewn unrhyw lle sydd yn agos i cartrefi bobl yn Neu Wynedd er enghraifft, a dwi'n siŵr bod hyn yn wir am llefydd eraill wledig yng Ngwynedd. Diolch.
Right, Chris, if you want to comment on that.
Absolutely agree with you, Linda, and I'm very happy to give that commitment to the West Area team, which of course is specifically related to Dolgellau Community Hospital. Already have an action plan in place to move things forward. They minimise as far as possible the closures, but any closure does have an impact in a rural area, particularly a rural area that is popular for tourism, for all the reasons that you've just mentioned. So they are minded to increase their staffing contingent upon training. You will be aware that training an extended scope practitioner to run a minor injuries unit does require some support, but I have seen the plan that the team have got in place. We will go back and just make sure that absolutely every option that we have to speed that up is being played through, but I'll give that commitment without any hesitancy at all.
And just to add to that, I'm working collaboratively with Chris on that, because there is work being undertaken across secondary care and the area to see how we can support the staffing and that. I do think we've got to look at different staffing models, but all of those things are in the mix. And we have had MIUs for similar reasons, including, as I go back, we've got a number of reasons why staff aren't present, including self-isolation in some areas. We've seen some of that in the East as well. So we've seen the impact North Wales wide, and we do completely understand the impact this not only has on our patients, their ability to get somewhere that's less local, but on our ED department. So it is a priority.
Okay, thanks both. Diolch, Linda. Johnny, you wanted to come back in?
Sorry, Mark. No, is my hand still up? I'll take it down.
Thanks. Thank you. So Mark, a couple of questions from me. Well, the first is directed to Joe, actually. So Joe, could you let the board know where we are, please, in terms of the dialogue with Welsh Government about the diagnostic and treatment centres? We cleared the business case as a board. I know dialogue's been taking place. I'm concerned that it's a priority for us, and a priority it will be for our communities. So what's the update, Joe?
Thank you. Actually very timely. Following the conversations at this morning's North Wales meeting, Dr. Goodall was extremely explicit about the size of the waiting list challenge at the Cabinet meeting today. And by agreement, I followed up with references, not specifically to the DTC in that fora, but more generally about the need for long-term capacity in North Wales to balance our demand for planned care and our capacity to provide that care in North Wales. And his response was, quote, helpful in terms of the range of the conversations that he is managing within Welsh Government. We're clear, working in partnership with colleagues at the Welsh Government Delivery Unit around the work that we need to do to support the conversations Welsh Government are seeking to have with colleagues with regard to the opportunities for a partnership approach with regard to the provision of facilities associated with a DTC. And those conversations are proceeding positively. with a strong indication that ourselves and one other health board are seen as being, in inverted commas, front runners for these kinds of conversations. That's that's a very nice general update. However, as I know the board are keen to ensure that there's a clarity around an endpoint to these enabling conversations, so that we can continue to make progress in order to create the capacity that we believe we need to deliver a sustainable, long-standing reduction in waiting time numbers in North Wales. My view is that the conversations have a little while yet to run in partnership with our colleagues in Welsh Government, but I would expect you to ask for a further update at our next board meeting, by which time we should be clear which approach we are continuing to use: the traditional DTC approach as per the business case, which stands approved by this board, or the alternative, more speedy partnership approach, which is under active discussion at this moment in time. Thank you.
Joe, bearing in mind the next board meeting is 2 months away, can I suggest that you and I review the situation perhaps in 2 weeks, and if not had a positive signal or some sense of a clear deadline for resolution, then we consider writing formally, or I consider writing formally to the Minister.
Very comfortable with that suggestion, Mark. I think that's deliverable.
Okay, thank you. Yeah. So, Mark, I've got a couple of other questions associated with this report. And it's the fact there are references in different places, Mark, to business cases under consideration. For example, endoscopy is one. There's a reference under RTT to outsourcing in a business case, and I know there's other consideration going on around cataract and cataract centre. Could at some point, Mark, the board have greater clarity around which business cases are active in the conversations within the executive team, and when we're likely to know what the executive team want to or intend to move on? Because I think it goes to the heart of some of the challenges that we face, which are alluded to in this report. But I think we need greater clarity about what's moving forward and what's not.
So I think one part of that we're now doing via the business case tracker, which details all the business cases, both revenue and capital. And I think from memory, that's due to go to the next meeting of the FMP. So I think that provides one route to give clarity. But of course, we can of course do that in other settings, or to board members outside if the board would find it helpful.
I would, Mark.
Okay.
Joe was nodding as well. I think Jill was as well. Okay, thank you. So I will now move us off that item. So I don't see any other questions being listed, and we'll go into the finance reports of month 1 and 2. So can we do what we traditionally do, take these as read and perhaps concentrate on the second of the reports, because that's the most recent and relevant?
Hi, Mark. Yes, of course. So thank you for the intro to the finance report. So the focus on the month 2 report really is to be considered in light of the revised annual plan, which was submitted to Welsh Government at the end of June, which the board is considering later on the agenda. So the Health Board is currently forecasting a break-even position for the year, having delivered a break-even position at month 2. And at this stage, I just wanted to remind the board that the financial forecast includes the 82 million of Welsh Government strategic support that we have received this year, 40 million of which relates to the deficit cover, 30 million for performance improvement, and 12 million for mental health, learning disabilities, and capacity and capability across the organisation. And it also now includes the 19.9 million that we have received after successfully bidding against the COVID-19 100 million recovery funding announced for Wales. The financial impact of COVID-19 is obviously still a significant factor in our financial reporting as well. And the current estimate was around £100 million this year, which is in light of the 169 million that we eventually incurred last year, and that is fully funded by Welsh Government. I think I would probably leave the update there, but I'm happy to take any questions from the committee, from the board. Thank you.
Okay, thanks, Sue. John, as Chair of Finance Performance Committee, is there anything you wish to add?
Nothing too specific. I think the main conclusions for me and the committee was that, no, we've still got some concerns about the initial savings performance, but it's a positive forecast to break even as we're going forward in the year. So nothing too great in terms of concerns at the moment, but just a slight note of caution around savings.
Okay, so can I just be clear, Sue? Because there's reference to a variety of funding streams and covering the lack of delivery of savings last year. So do we still need to deliver £17 million worth of savings this year to break even?
We do. It's currently included in the forecast.
Right, okay. So that goes to John's point about concerns to ensure that those savings are delivered in some way, shape or form.
Yeah, we discussed that in the executive team meeting yesterday morning.
Yeah.
And we are starting to do monthly meetings with all of the divisional directors just to get clarity around those savings programs. Obviously, the FDU has recently launched a vault of information around benchmarking opportunities, and all of the CFOs are actually currently reviewing that data to make sure that they are aware of the main opportunities for their own area. And we're having a sort of a workshop on that later this month. So I'm hopeful that will deliver, more confidence in the savings forecast. But we need to bear in mind that we delivered 18 million last year during COVID. So that was why we set the target at 17 million, because it's a realistic number for us to deliver.
Okay, so just to confirm, so you're assuming responsibility with the executive team as Director of Finance for the savings delivery.
Yeah.
You discussed it yesterday. There's work in train, but you'll be reporting progress to Finance Performance Committee.
I will.
Yeah. Okay. Any other questions around the finance report? I can't see any notified. So, okay, we'll move off of those two reports. Thanks, Sue. Those reports are noted by the board. So we come on to the group chair's assurance reports. Again, I'm going to take these as read. And a number don't seek to escalate any matters to the board. So I will briefly turn to them and then ask the chairs if there's any particularly one to highlight. So Medwyn first, the Audit Committee report.
Diolch yn fawr iawn, Mark. Diolch yn fawr, Cadeirydd. Pwyllgor archwilio ar y 10fed o Chweched o Fehefin. Cyfarfod hir ag eitha cynhesfawr, fel ydych chi'n gweld o'r papur. O safbwynt materion sydd angen i'w gyfeirio i'r bwrdd, mae o gyd wedi cael ei restru yn y papur, rhestr hawliadau ariannol, angen nodi rhestr hawliadau a gymeradwywydd yn y pwyllgor. Nodi cymeradwyaeth y pwyllgor i strategaeth a'r polisi risg, a fyddwn ni'n trafod hwnna nes ymlaen. Derbyn y gyfres o adroddiadau blynyddol y pwyllgora a cymeradwy o fframwaith llywodraethu integredig, a da ni'n trafod hynna nes ymlaen. Ond hefyd i nodi y pryderon y godwyd gan y bwyllgor mewn berthynas ag adroddiad sicrwydd cyfynedig ynglyn â staff dros dro. Oedd bod yr adroddiad yn eithriadol o siomedig o gofio bod y problemau wedi cael ei nodi mwy na 12 mis yn gynharach. A hefyd y ffaith fod yn ôl yr pwyllgor ag fi fel cadeirydd fod o'n anerbyniol bod yr archwilwyr wedi cael anhawster i gael gwybodaeth gan dîm y gweithlu ar yr amser oedd nhw angen y gwaith i gael ei rhaid i fiawn iddyn nhw. Os o bwynt gweddill mae'r papur yna i chi weld, jyst isio cadarnhau'r ffaith y safbwynt adroddiad sicrwydd cymunedig o staff dros tro oedd y prif weithredwraig yna, ac ddudodd hi bod hi'n mynd i cymryd y mater a mynd ymlaen, a bydd hi'n falle'n gallu adroddi ni heddiw yma ynglyn â'r canlyniad yr penderfyniad i wneud rhywbeth ynglyn â'r peth.
Okay, thanks, Medwyn. So the section dealing with matters requiring escalation to the board, we're asked to note a variety of things, including the concerns about the interim staffing limited assurance report, which, as I think Medwyn knows, I picked up at the time with the interim chief executive and also the director of workforce. And to note in particular the approval of the integrated governance framework. Are we happy to do that? Yes?
Yes.
Yes.
Okay, thank you. Thanks. Yeah, Medwyn. So, Lucy, 4th of May, so quite some time ago. Anything you want to highlight from the QSE assurance report?
Thank you, Chairman. I updated the board at the last meeting in relation to the May agenda, actually, regarding particularly vascular and the YGC improvement plan items. I don't have anything further to highlight from that particular meeting, but I'm happy to answer any questions.
Thanks, Lucy. I don't see any questions, so we'll move on. Finance Performance Committee, John.
Really just to highlight the key risks around unscheduled care, which we've talked about with the continued pressures and the planned care side, but acknowledging that there's work going on to deal with that. Those really are the key concerns from the Finance Committee point of view at the moment.
Thanks, John. So, Charitable Funds Committee, Jackie, anything from you?
Thanks, Mark. There's nothing to highlight apart from the fact that we've just approved the ethical policy for charitable funds. So thank you for that.
We have, thank you. Mental Health Act Committee, Lucy.
Thank you, Chair. Yes, I just wanted to highlight, we received the annual report for deprivation of liberties and discuss the implications of the new liberty protection safeguards, which are due to come into force next year under the new legislation. The resource implications of this particular area are significant as a result of both the changes to the process under the new legislation and the anticipated increase in numbers. So as you can see from my report, a task and finish group has been established, but this is an area under particular scrutiny at the moment, and I'll be seeking assurance on this as it progresses.
Okay, thanks, Lucy. You are breaking up a bit, but I got most of that. So thank you. RATS, the report is there. I've got nothing that I wish to escalate to board. We have SPPH committee next. Lynn,
thank you, Chair. You'll see that we covered a whole range of issues and we went into detail on each one. If I'd just like to identify some of the key risks, we were concerned that the business continuity plans hadn't yet evidenced that we were able to test them as part of the major incident planning, and we're expecting a report at our next meeting. We did note that we need to spend more time on the Regional Partnership Board, and that will be a focus of a workshop in the imminent future. So matters to be escalated to the board is to ask you to receive the annual equality report. And I took the liberty, which is very unusual in these chairs updates, is to ask for a summary to be attached. I just felt there was such good work that was being done that it was valid and right that we recognise all the excellent work. Thank you.
I agree, and I'm sure we've all read and noted that, Jill. Lynn, thanks for doing that.
Thank you.
I don't see any questions listed. So John, DRGC committee. Thanks, Lynn.
It didn't go off mute, sorry. The reports as read, I think there are two key issues to raise to the board, one of which we've talked about, which is CCTV. There are some real concerns there in terms of the lack of management and the lack of policy around the CCT systems we've got in the organisation, and that's exposing us to some significant risk and inability to actually deal with some of the issues that it should be contributing to. The other one is keynotes and alerts, which is to do with the patient administration systems. We're at risk of not fully complying with Data Protection Act if we don't get a handle on that. So I'm hoping that we can get some clear commitment to addressing both of those issues.
So I think we got the first, did we not, from Peter in terms of CCTV? Yes. So we're now on to the keynotes and alerts. Was Chris at the meeting as their executive lead for digital? Chris, were you there? And are you undertaking to take it away?
Yes and yes.
Okay. So will you update John outside in due course, Chris?
Yeah, very happy to.
All right, thanks, Chris. I'm assuming it'll come back as well via the committee as well in terms of an update, or wherever we're left with committees. Cheers.
Okay, thanks. So next report is Stakeholder Reference Group. Claire's not with us, Mark. Mark, is there anything you want to highlight from this report? You're on mute, Mark.
Sorry, just to advise the board that I'm pleased to be working with Claire Budden, who is the chair designate for the SRG. Ministerial approval, I understand, is awaited on that appointment, and also Councillor Mike Parry being elected as the vice chair of the SRG. There's nothing I wish to highlight on the report, Mark. Thank you.
I can confirm that is correct, Mark, and we are chasing the approvals. Thank you. Health Partnerships Forum. Gareth, from you.
Yeah, a couple of things, Mark, if I may. Meeting was a number of weeks ago, but we've received presentations on primary care in North Wales and on the Stronger Together work programme. I think the forum was keen just to provide some advice, which is set out in the document on that. Particularly in terms of primary care, we were really keen to advise the importance of primary care in providing involvement and indeed leadership in the planned care transformation programme in the Health Board. And we particularly referenced the development of the diagnostic and treatment centres, I think, as an example of where they're important in relation to the development of the clinical pathways and the clinical model for that particular business case. And then for the Stronger Together work programme, which was well supported by the forum, we felt there were a couple of areas which would hopefully strengthen the success of that programme. First one was to ensure that the independent contractor element of the organisation were able to be involved and their voice was able to come through. And then secondly, that there was an attempt really in the presentation to the workforce about the programme that there was some clarity in relation to what was different this time as opposed to previous engagement attempts over the years, and that we had a process whereby some issues that people will raise were able to be dealt with perhaps more short term, as opposed to the thematic analysis that would come through this work that would then inform longer term design within the organisation. Thank you.
Thanks, Gareth. So I'm sure that all of that has been noted, particularly by the lead executive as present. So we'll now move on to Local Partnership Forum. There's a note here from Jan and Sue. Neither of them are with us. There's some observations in terms of feedback to the board, particularly around Stronger Together, which I'm sure Sue will have noted, and as reference to Ellen undertaking a significant piece of work, which I'm sure has been noted too, certainly by me. So I won't dwell on that report either, and we'll move off the Chair's assurance reports. Thank you. On to the HIW annual report. Jill, and I think we've just been joined by HIW. It's shown as with you, Jill. Are you introducing it and moving on to Catherine?
Yes, I will hand straight over to Catherine actually as she presents her annual findings both across Wales and more locally. So thank you, Catherine, for joining us.
Thanks for having me, Jill. Really appreciated. The only problem I'm having, Kate, is that it says that the host has disabled screen sharing. So that might be a bit of a problem. I have sent the presentation over ahead of time, so I'm not sure if Kate can share that.
Okay, I have got it loaded. I'll share it now if you want to just start presenting, Catherine.
No worries. Okay, so I'm Catherine Williams, and I've recently become a sort of temporary relationship manager for BCUHB. So having a nice time getting to know Jill and Matt and all the people we engage with on a regular basis. I'm also the Assistant Director of Quality and Clinical Advice over at HIW, and I've come along, as Jill said, just to sort of trot through our annual findings, so hopefully nothing new to you, as they would have been through our reports throughout the year, but just to give you a bit of Wales context as well. So I'm just going to give you a quick introduction, talk you through our adapted approach, go through a little bit of the Wales background and context, then a bit of work around BCU, what we've done in BCU, and also some of those key themes and findings as well. So from our perspective, as you know, we're the Independent Inspectorate of Regulator and Regulator of Healthcare in Wales. Our main purpose and our goal is to check and ensure that people in Wales are receiving good quality healthcare. And as you will already be aware, our main values are to be independent, objective, caring, collaborative and authoritative. So there's a number of ways that we attempt to provide assurance, and that can be through our intelligence, our inspection programme, and also a big part of our role is promoting improvement, and really helping healthcare providers get to that place of improvement. And finally, we do have quite a significant role in influencing the policy and standards around healthcare in Wales. So obviously the last year and a half, I don't need to tell you, has been different and incredibly challenging for the health service as a whole. In response to that, we took an adapted approach very early on and decided not to undertake routine on-site inspections. And the main reason for that was because we were in a pandemic, but also around that huge pressure that was being felt within particularly the NHS sector of healthcare, and how our presence may contribute to that pressure. So that was a decision we took early last year, and that was reviewed quite frequently. So whilst we didn't undertake routine on-site inspections, we did maintain oversight, and we did that through working with partners like Welsh Government, the community health councils and other stakeholders, and that formed part of our ongoing review of information and intelligence. Some of that led to on-site activity, so where we needed to have a look at something on site, we have done that. Where the risk has indicated we needed to do that. We've also been involved in the scenario modelling with Welsh Government, and also liaised very closely with Public Health Wales on their surveillance information, and also to gain their advice on when would be the right time for us to go back into doing routine inspections, and also putting those safeguards in place if we needed to go in when COVID was in high public circulation. We looked at some new ways of working to check on care. So we did it through discharging our normal statutory functions, and that included sort of remote interviews, adapting some of the internal ways that we worked. The approach that we took was very flexible. We introduced quality checks, which you will be aware of, which were a remote way of us being able to dip in, check the quality of services, provide some level of information to you as a board, and also some assurance to the public. The main purpose of that, again, was to reduce that burden on the system when you were under significant pressure, and they've been generally quite well received during that time. There's also been the consideration of safety of our own staff, so we've taken a number of measures to make sure that our staff are protected when they're going out to do any on-site activity. So when we looked at our quality checks, I know you and BCU have had a number of quality checks now. So they've been conducted entirely off-site. And there's been a bit of a blended approach. There is our standard quality check where we've just been doing a remote interview. It's an hour's call looking at some information we've had back. And then in some more complex settings, we've had things like record reviews and further interviews with staff if we needed to. And the design of those quality check, that whole process was to align to the key areas set out in the NHS Wales planning framework. So what we looked at specifically was infection control, prevention, governance, particularly around staffing and how that was managed, and the environment of where the care was being provided. So taking into account things like social distancing and the huge impact that that had on the environment that your staff were delivering care in. So we looked at these quality checks as a whole, but then we also had specific methodology for different areas. So we had a specific methodology, say, for general practice, medical wards, say, to urgent care, and it explored specifically the arrangements around COVID-19 and how staff were feeling supported in that and how they were able to deliver care within that really difficult time. So in terms of our Wales activity, we didn't complete that many on-site inspections last year due to the stoppage of our routine work. So we completed 18 on-site inspections, 90 quality checks, 5 remote NHS follow-up activities, 5 remote IRMA inspections across different establishments, and we handled over 1,000 calls through our first point of contact service. And as a result of that, and through our website, we dealt with 439 concerns, and 36 of those were classified as urgent. In terms of our on-site work, it's just a bit of a breakdown here for you. So as you can see, we did 8 mass vaccination centres, including some in BCU, which were very positive. We did dental practices, mental health settings, and then you can see our follow-up work were predominantly NHS, and the field hospital quality check was a bit of an outlier in terms of we just did 1 quality check on the field hospital, and that was within BCU. And then we did the majority of quality checks within NHS hospitals and GPs. So the themes that we've pulled out from across Wales is that we found that there was a really good overall standard of care delivered across Wales, particularly in the face of an unprecedented challenge that the pandemic presented. We also found that there was a rapid response from services in adapting environments and introducing new ways of working and delivery to make sure that those essential services continued, which was really positive to see. There were a number of services that had implemented innovative, really forward-thinking approaches to support patients' physical and mental well-being, and I know some of those were found within BCU, some of those really good sort of examples of positive practice to support patients' physical and mental well-being. There were a wide range of changes to infection control and prevention arrangements, and we found that generally there was a very good response to those, and that the outbreaks during the second wave highlighted that there was still a bit of a need to look at some of those arrangements, but generally there was a very positive response to those. And finally, on the All Wales front, and definitely relevant to Betsy, having been involved in some of the activity there, staff at all levels have demonstrated absolute tireless commitment and flexibility during the pandemic, and as you can imagine and as you know, we feel that that's really impacted on their well-being, and it will be a task in the future for the NHS and other healthcare providers to support staff out of that, but really showed a shining example of healthcare across Wales. So getting on to BCU HB, In that period, we did 2 GP quality checks, 3 NHS hospital quality checks, 1 field hospital quality check. We undertook 4 mental health quality checks, 1 on-site inspection, 1 for a mental health hospital, 1 dental on-site inspection, and 2 mass vaccination centres, and then 3 follow-up pieces of work which were conducted remotely, and an IRMA inspection which was also conducted remotely. So our key findings around BCUHB have been, where we have inspected or done any activity, we've found that patients always told us that they felt very well treated, and they felt they were treated with respect by staff, and they felt the quality of the care that they received was a good standard. We found that across the health board, as per the Wales findings, services had adapted incredibly well to the challenges of COVID, and all staff across all activities within BCUHB showed a really strong commitment and resilience in the face of the pandemic and the huge challenges that had presented to them. There are still some issues of concern around mental health services within the health board, but I just wanted to say that what I have found, certainly from being a relationship manager thus far, is that it's clear that the health board has got a really good commitment, a strong commitment to improving services, and from what we've seen, that approach is proactive and responsive as concerns have emerged. So while we still continue to receive concerns regarding mental health, we're assured that the health board is doing everything it can to respond to those as those concerns emerge. The other theme that we found was around that sometimes action isn't always taken as a result of audits, risk assessments, and incidents. So whilst action might be planned, some of that action isn't always taken in the most timely way it could be. And that includes things like where, say, a policy has been identified as needing updating, perhaps that's not being updated as quickly as it could. So that's something we'll continue to monitor in the coming year. In terms of our hospital activities within BCUHB, I've highlighted 3 very positive and 3 things that may need some improvement over the next year. So the positive findings are that, again, we found services adapted incredibly well to meet the challenges. Staff were dedicated, caring, compassionate in their approach. Particularly in environments with COVID positive patients. So for example, the field hospital staff were very caring towards those patients. And we found that the infection control and prevention arrangements that BCU had put in place were actually very good and flagged up as a positive to other health boards across Wales. Some of the areas where we think some improvement could be made, again, around that action resulting from audits and risk assessments, particularly in relation to IPC and COVID, do need to be followed up in a more timely way. There remains some concern over staff vacancies, which links into an all Wales theme, but that was something that still came out. And although there's been actions to improve patient flow and they're absolutely recognised, there are still some improvements that we think could be made to those areas. In terms of mental health, we found that services again had adapted to the pandemic very well, and particularly around the environment and the awareness of the risks that were present, particularly in this patient group. We found that actually those adaptations have been taken very well with good governance. We found again that in the infection control and prevention arrangements, including the dedicated areas for COVID suspected patients, were very well embedded and working well. There's some other areas of improvement. So the pressures of the pandemic had led to the services reconfiguring to meet the demand, and that had placed some challenges in the way, including making sure that there was appropriate placements for patients, which again, in the face of the pandemic is very difficult to do. We acknowledge that, but that again is something we'll be monitoring. Again, an issue around the policies being regularly reviewed and updated and communicated to staff. Again, again, that's around the actions not being followed up in a very timely way in all cases. And again, as I talked about earlier, we are still receiving and have been receiving a number of concerns regarding mental health services. Now we're following those up and we're working very closely with the patient safety team on those, but I thought it was worth highlighting. In terms of general practice and dental activities, we found again COVID-19 arrangements and infection control arrangements were being implemented effectively, and the environment and access arrangements for general practice and dental had been adapted to make sure patients were safe but could still access those services. One of the themes that came out that we thought maybe could improve was around some staff still required infection control and prevention training and personal protective equipment training, which obviously during the pandemic was really important. And also some of the audit and training information was not always easily accessible at the time of inspection, and there was a number of training courses which were identified as being out of date. And obviously we've given a bit of leeway of that with being in the pandemic and being under such a pressured situation, but some of the training related to things like life support and infection control, so key training areas. Around other sort of on-site inspections, that's the remote stuff, we looked at dental, mass vaccination centres and mental health. From a good practice point of view, we found some really positive practice within the mass vaccination centre, very good arrangements and planning, governance around those centres, and a really positive inspection of those centres. And again, we shared that those positive findings across other areas of Wales, and so other health boards could take note of those. Specifically around the enhanced infection control arrangements, that again was a bit of a theme all through BCUHB last year of how well you'd responded to the pandemic and adapted your infection control and prevention arrangements. And also we found that certainly on the on-site inspections, there were very good and effective governance arrangements in place, particularly in reference to the mass vaccination centres. So some areas which could have been improved in terms of the on-site inspections. So documentation required improvements in some areas, so not always completed fully, and perhaps not completed with signatures, dates, etc. Some staff training wasn't up to date due to courses not being available, which is completely understandable, but that is something we'll be monitoring going into the next year around how the health board recovers those training numbers for staff. And in terms of the way sometimes that medication stock is disposed and stored and labelled, could have been slightly better. And that's it. Hopefully that wasn't too quick, but if anyone's got any questions, I'm happy to take them, or if there's any comments on the presentation at all.
Okay, that was not too quick. Thank you, Catherine. So any questions for anyone? Lucy.
Thanks, Chair. Thanks for that, Catherine. That was a very helpful presentation. Of course, we have been receiving BHIW reports at QSE committee, which I chair. The question I had, I suppose, was around the mental health services. So we know that improvements have been made, but we also know that those improvements are still quite fragile, and it's going to take some time to actually get those embedded. And I do appreciate your acknowledgement in that area, because the staff are motivated now, and that we've got a good leadership team in now to try and move things forward. The nature of the concerns that you're still receiving, though, do they tend to be related more to sort of staffing issues or patient safety issues? I mean, I've seen your findings, but I'd be interested in your view on it.
I think there's a bit of a mix of concerns. Where we get themes in and things we can share with the health board, we do share them, and we work really closely with Matt within the patient safety team to make sure the health board are aware of any concerns we get through as well, albeit if they need to be anonymised. I don't think I can go into the detail of those being a public forum, but certainly we engage very closely with Matt and the team around the themes in those concerns, and completely acknowledge, Lucy, that this is a journey for mental health services, and you know, that's why we're working so closely with the Health Board to keep an eye on that service, and you know, acknowledge that it's not a 24-hour turnaround, it's more of a long-term turnaround.
Thanks for that, Catherine. And yes, of course, I appreciate you can't go into too much detail. I mean, we are hoping that the Stronger Together piece will also help, because there's a change in culture that's required within the division, which is already being done, and the maturity matrices that have been pulled together for targeted intervention. The cultural side is underpinning all of that work. So I look forward to hopefully receiving more positive reports from mental health, but you have also identified some positive areas as well. So just to assure everyone, we are trying to address those areas. Thank you.
Okay, thanks, Catherine, and thanks for giving up your time to be here and present the report. And Joe and I look forward to seeing you again at our next liaison meeting.
Lovely. Thanks for having me, Mark. Take care. Bye.
We will. So we'll now move on to the NHS Wales staff survey update, which I think is with you, Leslie, but we may have others in attendance as well.
We do. We've got Alan Greer, who's acting AD for OD, and Nia Thomas, who's head of OT. So basically, I'm going to hand over to them. You'll just see from the general update that it was a particularly challenging time to do a cross BCU staff survey, and consequently the participation rate was quite a bit lower than we would normally expect. But so Nia and Alan will explain more.
Thank you, Leslie. Good morning, good afternoon, everyone. What I'm going to do, Nia was the author of the report, so I'm going to let Nia take us through the report, and I'm sure board members have read it. So Nia's just going to pull out some of the key issues and the key themes, and then I'm sure we'll get into a bit of a discussion. So I'll just hand over to Nia. Thank you.
Thank you very much, Ellen. Thanks, Leslie. Thank you for the opportunity to come this afternoon and present the paper to you. So the paper provides an update on the full NHS Wales staff survey that took place in November 2020. The implementation of this survey was significantly different to previous years. Therefore, direct comparisons with the 2018 survey is not as feasible as would have been between the 2018 survey and 2016. Some of the significant differences include length of time the survey was open, so from 3 weeks in 2020 as opposed to 8 weeks in 2018. Paper copies were not available, so it was a purely electronic means of completion, but this was an open link that was sent to every member of staff, and it could be used on any device, so it could be used on a smartphone or tablet, etc. And also 21 questions as opposed to the 80 that we saw in 2018. And the method of feedback has a much bigger emphasis on team level feedback and improvements. The response rate, as Leslie has mentioned, was 18%. The national overall response rate was 20%. And some of the main themes which are positive are around the engagement, experience of work and bullying, harassment and abuse, and some of the key areas for development and impactful change are around how the organisation takes action in terms of bullying and harassment and abuse, staff being involved in discussions and decisions on changes that happen within the department or team, and also teams taking time out to reflect and learn. So the actions taken to date to support the key areas for impactful change include the review of raising concerns. The new Working Confidence platform has been launched, and there is an established multidisciplinary team that meets to discuss the concerns raised. And also the Speak Out Safely Guardian interviews are being held tomorrow. Mewn undod mae nerth, so Stronger Together, I'm sure you're aware of, this is a key organisational development and system review, which seeks to engage with in the region of 1,800 staff, which will be 10% of the organisation. And their voice throughout the 3 stages of discovery, design and delivery will be crucial, especially the element of continuous feedback and staff being able to see how their feedback is being taken through to the design and delivery phases of the work and how we reflect and learn from the feedback that they give us. The team level developments that we've been working on also includes the Be Proud Pioneer programme, of which there are 14 teams currently on programme and 44 have been through that programme in total. So that is all about looking at the staff engagement behaviours and feelings that staff have towards the team and the wider organisation and making improvements based on those surveys that they do locally within the team. We've also got a new matrons programme that's been launched in April this year, and we currently have 13 matrons, and that's all about developing those matrons and the skills in terms of people management and higher level leadership skills to engage with staff. Some of the online engagement tools that have been developed recently and that we're using in the organisation now that we've moved to more of a virtual platform for our day-to-day work has been to support the staff feedback. Those are being shared widely with the organisation, and we've recently done a demonstration to the Safe Clean Care Harm-Free Steering Group, and they found those tools extremely effective in terms of gaining staff feedback and how we can then report that feedback back in terms of what actions have been taken as a result. There's also the development of the organisational and leadership strategy for 2022-25 that will also review the feedback provided via Stronger Together, the Be Proud surveys and also the National Staff Survey. In moving forward, some of the key focus areas will be increasing participation in future surveys and making use of pulse surveys that is available on the ClearSight platform. So looking at which areas need support with feedback, which areas need support with improvement, and targeting some of the pulse surveys to those services. And also strengthening the team level improvements and ownership of the feedback at the local level through established meetings such as the integrated workforce improvements groups that each division have. So Ellen, I'm not sure if you want to say anything in addition.
No, Nia, I think you've covered well the different approach to the national survey last November, and of course last November we were just heading into the unfortunately the second wave of COVID. So the approach was different, the number of questions were different, the timeline, the time to respond. And just I think the key thing is that emphasis on going forward that national and indeed pulse surveys are more about teams and having team results and managers working with staff to co-create improvement plans and being able to measure pre and post, and that will be the theme going on. And I think one of the things, of course, if we are encouraging, and indeed we will be encouraging greater levels of participation, I think it helps if to encourage staff to get involved if they see that they're involved in development of plans and they're involved in measuring improvements and have that voice. They are probably therefore more likely to participate in future national surveys, so that we can keep that monitoring, and indeed in pulse surveys as well. So I think that's one of the key learning from national survey from last year. And I think is it September, October this year where the next national survey is planned, and we have a rep on that, the national group designing that and implementing it. I think the other thing I would add is the importance of the new integrated workforce groups that are divisional, and they were set up between the survey in 2018 and 2020. There was an internal audit review of national staff survey results as well, and one of the recommendations from that was the establishment of those divisional groups, so that that's a key forum for the next survey that we do, and any pulse surveys we do, to engage those seniors in making sure that line managers and staff are fully engaged.
Okay, thanks to all three of you. So before I open it up, I'm conscious this has been to SPPH a couple of times. Lynn, is there anything you wanted to say as chair of SPPH?
We went through it in quite some detail. We were concerned over the fact that it couldn't be compared and contrasted to previous reports, and we did question why that was the case. We're very much in favour of being team-based. And if I just pick up on something that Alan said, the audit report actually gave limited assurance. Please correct me if I'm wrong. So the lessons that we need to be learnt on team working really do have to be implemented, and they need to be implemented by each area of work. And that will, I imagine, be checked up again by the audit committee. We also appreciate how it will fit in with Stronger Together, and it should all tie together.
Absolutely.
Yeah. And we welcome further reports. Thank you.
Okay, thanks, Lynn. Any further questions or observations? Lucy.
Thank you, Chair. And thank you for that. And first of all, before I actually go to my observation, I just wanted to say that I'm really hopeful that both the Stronger Together programme, which is a significant piece of work, and I don't envy the team actually that are conducting it and pulling together all of the information that they've gathered, because I believe it is absolutely phenomenal. But that should provide us with a really good baseline going forwards as to how we can, what we need to address and how we need to address it across the organisation. But of course, that isn't just that's not on the back of the staff survey. That's been undertaken as part of a wider organisational development piece. And I'm also hoping that the new Speak Out Safe Guardian post is also going to be really helpful. I'm glad you've commented that we're going to be interviewing tomorrow for that. When I read through this report, though, one of my biggest concerns actually is the question about if a friend or relative needed treatment, I'd be happy with the standard of care provided by my organisation. Now that's a pretty low score and really does concern me. Now the things that you've laid out in how we're responding to, the different initiatives that we're doing aren't actually in response to the survey results themselves. They were being done anyway. So my question is, what is actually being done to respond to this, and particularly that element? Because I appreciate that comes under patient safety, which of course we are focusing on in QSE committee. But this is about staff perception as much as it is actually about the standard of care being provided.
Thank you, Lucy. I think some of the actions that we've outlined, so the Be Proud Pioneer Programme, the Matron Programme, have started since relaunched the Be Proud and Start the Matron Programme sort of this year. But in terms of your particular point around the friends and family requests, in terms of having those discussions locally about what does that mean, what do we need to do, how do we need to improve that would be part of those kind of team-based discussions. And of course the teams will have their own reports back on, if you like, their scores for all of the questions for that one. So what is it we need to do as a team? How are we getting feedback? How are we using that? And it may well be a very useful use of the quarterly pulse surveys. So if there's a particular theme such as that or another, that we actually run those over a period of time to see, so rather than wait for a next national survey, for example, for 12 months, that we do it quarterly on key themes with our co-created improvement plan and saying, is this making a difference? And
also, Ellen, just to add to that, that is a key part of the Be Proud Pioneer Programme as well. So that question is within that team level working as well. So we are able to track with those teams how that score is improving over time as well.
Okay, thank you very much. That's very helpful.
Okay. Linda, I think you've got a question.
Diolch, Mr Cadeirydd. Ga I ofyn I Nia, dwi'n gwybod mae o'n wastad yn her i ceisio deall yn well be mae staff yn meddwl a be maen nhw'n meddwl am ei gwaith. Mae 80%, dros 80% o staff ddim wedi cymeryd rhan. Ac dwi'n derbyn bod hyn ar draws Cymru gyfan yn rhywbeth weddol cyffredin. Sut ydyn ni'n mynd i ffindio allan be mae'r 80% yna yn meddwl? Mae'n un beth i ceisio codi y nifer, ac yn amlwg mae tua 20% o'r staff yn fodlon cymeryd rhan. Ond sgennych chi ryw syniadau beth sydd yn achosi yr 80 sydd ddim yn cymeryd rhan i beidio cymeryd rhan? So hynny yw, dwi'n meddwl, mwyn i ni deall hynny, byddwn ni ddim yn gallu codi y nifer os da ni ddim yn deall be di'r rhwystrau ac neu hwyrach bod pethau yn, dwi ddim yn siŵr bod ar sail, ydyn ni'n deall neu ydyn ni'n sylweddoli beth ydy'r problemau yn y man yma. Diolch.
Diolch, Linda. Wel, mae'n heriol iawn i drio cael staff i lenwi'r survey fewn lle. A beth da ni'n ffeindio di bod yr adborth mae bobl yn gael ar ôl y survey, bod hwnna'n yn rhan hanfodol o sut ydyn ni'n rhoi yr adborth yna i staff o be da ni wedi wneud. Da ni wedi gwrando na chi, be da ni rwan wedi wneud ar ôl yr adborth da chi wedi rhoi. Dwi'n meddwl mai mewn undod mae'n nerth, mae hwnna mynd i fod yn rhan allweddol, hollol allweddol, o sut ydyn ni'n gwrando ar staff, sut ydyn ni yn dysgu o'r adborth mae staff wedi rhoi i ni, sut ydyn ni'n cadw mewn cysylltiad hefo'r staff sydd wedi rhoi yr adborth, a sut ydyn ni yn cynnwys y staff yna yn y datblygiadau a'r gwelliannau da ni'n mynd i roi yn ei le fel ydyn ni'n symud ymlaen fel sefydliad. So mae o wastad yn heriol. Dwi'n meddwl oedd yr adag oedden ni'n trio gwneud yr survey rwan yn heriol iawn. Oedd o just cyn i ni fynd i fewn i'r ail wef yn doedd o'r pandemig fel tai. Mi nathon ni fynd rownd ysbytai ag ati hefo iPads i helpu staff lenwi fe fewn. Mae mond 12% dwi'n meddwl nath ddefnyddio y dull o wneud y survey drwy'r papur yn yr survey 2018. Doedd na ddim yr dull yna o wneud yr survey trauma. So dwi'n meddwl ella bod hynna wedi bod reit heriol hefyd. Ond mi oedden ni'n trio deud wrth staff, fedrwch chi wneud ar eich ffôn eich hun, fedrwch chi wneud ar eich iPad, mond 20 cwestiwn sydd yna. So mi nathon ni fynd rownd amser cinio i'r ysbytai i jyst dweud, mae gennym ni yr methods yma i chi fedru gwneud y survey, please helpwch ni, cos da ni eisiau gwrando arna chi. A mae o wastad yn heriol, Linda, da ni wastad yn trio meddwl am ffyrdd i helpu staff i gymeryd rhan.
A derbyn hwnna'n llwyr ni a dwi yn cydymdeimlo efo hynny, ond dwi'n meddwl bod yn bwysig bod ni'n edrych ar hyn yn ei gyfanrwydd, oherwydd wneud ni yn cymeryd ar 20% sydd yn ateb felly fel dyna beth sut mae pawb yn teimlo. Ond ar ei bai bod ni'n deall be di teimlad yr 80% sydd ddim, mae'n bosib bod unrhyw cynlluniau sgynnon ni mynd yn ymlaen wedyn ddim yn seiliedig ar gwybodaeth cywir. Ond hollol derbyn yr llwyr bod hyn ddim yn hawdd. Diolch yn fawr iawn.
Diolch yn fawr.
Okay, thank you. Final question from me then. So in response to the last national survey, we put in, as I understand it, quite an infrastructure around the divisions and the expectation that they would develop their own action plans, respond to them, and they would be monitored. Of course, this details further measures to inform the response to this survey and future surveys. So to what extent are you very content that those mechanisms are going to do what you seek from them? And also, to what extent are you satisfied that the progress against the improvement plans that are referred to in the report are going to be sufficiently monitored to ensure and enable progress moving forward? Who wants to respond?
If I pick that up, so the staff survey and improvement plans are a standing item, agenda item on the respective divisional workforce groups. And then in terms of us kind of monitoring, so we're party to that, we're members of that. There's probably some learning between the different groups to be shared in terms of, you know, what enables improvement. Are there any barriers to improvement? How can we make those better? So the key vehicle is and should be those integrated workforce groups, because they're divisional, they have the seniors there, they are the kind of, if you like, the primary route through which, right, okay, where are your improvement plans? Where are your measures of improvement? How do you know? What's your evidence for that? How can we help you with that? Any barriers that you're having? How can we cross share between the divisions? Because there'll be some common barriers, and there'll be some different ones, and there'll be, you know, some really good areas of good practice. So how do we spread that through those groups?
Oh, we're also, as well, just to add to that, Ellen, we're putting this on the agenda for all of our leadership and management development programs. So we are asking all the leaders that come through the programs, how are they dealing with staff survey, staff engagement, staff feedback, and how are they taking those improvements forward? And we're also helping them with that development.
So you are content that the mechanisms being put in place will enable the organisation to focus on areas by which to improve, and also enable progress to be monitored. Yeah. Yes,
I would say, yeah.
It's an area we need to keep working on, and if that doesn't bear fruit, then we'll need to revisit what mechanisms we've got in place.
Okay, so can you keep, as Lynn requested, SPPH committee, soon to be PPH committee, kept up to date, please?
Yeah, absolutely.
Thank you. All right, so I'll draw a close there. Thanks for giving up your time to be with us. It's clearly a very, very important piece of work. We're concerned to ensure that the concerns of our staff are understood and responded to, and that they feel proud to work with us and for us. So thanks very much.
Okay, thank you. Thank you.
Thanks, Leslie, too. So I'll move us on again, if I may, just when I get there. So we're now onto the corporate risk register, which is with you, Jill.
Thank you, Mark. I am going to take the paper as read. If people have, it has been through varying committees. I think the point I would like to raise is that the QSC approved 2 risks for inclusion in the CRR Tier 1, which is pointed out in the report. And again, the DIGSI committee did similarly. They are included within the report for recommendation. Happy to take any questions. There's an awful lot of work going on in the report that has just been completed. So just to let people know that you will see this in a slightly different format from next month. And that's particularly regarding how we're going to be presenting the risks and their journey for improvement or reduction or otherwise.
Okay, thanks, Jill. So are there any observations or questions from anyone? Lucy.
Thanks very much. So we've had some ups and downs with this report coming to QSE committee, but I just wanted to clarify for the record that whilst we did approve the reduction in the target risk scores that are mentioned there in the report, it was on the basis that whilst the risk lead had started working through the actions, that had enabled them to appreciate that they could actually achieve a lower target risk score. And the reason I just wanted to clarify that is because the recommendation made to the committee didn't actually match that narrative. So it was more that the we were told the report actually said that the target risk score was being reduced because of the actions had been completed. So I just wanted to clarify that for the record, so that it's absolutely clear on the basis in which we reduce that target risk scores.
Thank you, Lucy. And just to support that comment, as I said, there's going to be a different presentation of this moving forward. And a lot of that was in response back to the committee challenges that we've had. I think that was really helpful, Lucy, and just in terms of language. The other point we have made clear that any changes in risks will not be accepted without the full ability to be able to challenge the risk owner. So that we've got that confirm and challenge that we are confident that the actions that are taking place are actually impacting reduction of the risk. So it's not just, as Lucy said, that the actions have taken place, but they are actually having an impact, and that can be evidence. And clearly the conversation is continuing about risk appetite, which is clearly a board conversation taking place.
Okay, right, thanks both. So Jill, we are asked to note and receive the report, which we do, to review it. As you say, it's been reviewed in a number of places. So on that basis, we support the recommendation. So I'll move us on now to decision items. And the first is the board assurance framework. Louise.
Thank you, Chair. Before you is the current cut of the board assurance framework. It's presented to the board here today for its 6-monthly review piece. This is the first 6-monthly review since the board approved the board assurance framework in its current guise, which was back in January. And we have 22 risks on the board assurance framework at this time. All have been subject to bi-monthly review across committees, subject to the appropriate cut across the committee. And there's been some really, really helpful check and challenge discussions there, which have been really helpful in terms of the ongoing development of the board assurance framework. And also the growing maturity of the risk management group, and also conversations at the audit committee workshop have really helped with the ongoing refinement and development of the BAF. Colleagues will note that the BAF is currently mapped across to our annual plan priorities and enablers where appropriate. This is almost a sort of interim position for us at the moment until we conclude the refresh of the Living Healthier Staying Well strategy, which will give us an opportunity to relook at the BAF risks, refine them down, really give them a strategic focus. So we're absolutely confident as a board that the board assurance framework is a tool for us to monitor the risks against our high level objectives. So we'll be able to move into that work towards the autumn time when that strategy refresh concludes. That again will give us an ability to refine the current number of BAF risks, which through the committees we're having discussions about some of those and their more operational nature. So we'll have the opportunity to do that. So I'll leave that there. In terms of the process, I know my exec colleagues will pick up as comments on individual BAF risks as the risk owners, but happy to take any comments on the process. Thank you.
Sorry, Dr. Louise, any questions or comments from anyone? John.
Thanks, Mark. It was really just a point of thank you for Dawn and yourself, Louise, in terms of I can see some of the feedback I provided around the key field guidance, for instance, has been incorporated, and I think it reads in a much better way and gives us the clarity we need in terms of the definitions of what we've got in the BAF. I think there are some comments that have been picked up elsewhere in terms of, are we being too specific in some of the BAF risks, that they are not generic enough? I think estates comes to mind, but I think that we can pick that up potentially through committee structure.
Thank you, John.
Thanks too, John. Lucy?
Thanks. Yeah, I echo John's comments actually in relation to the BAF itself. I think, you know, we know it's a work in progress, but we can see that how it's developing over time. I'm sorry, Louise. Are we covering questions now in relation to any of the specific ones, or are you going to take? We're covering those now. Okay.
We are.
Thanks. So just wanted to say, first of all, the BAF risk 2112 regarding security services. Of course, we picked this up at QSE, and I know we recognised at the time that changes wouldn't be made in time for the board today, and that you're going to be doing a deep dive, I think, in, is it September, for security services, but for noting for all members that we've asked for it to be reviewed, the risk score itself to be reviewed in the context of other risks, because it seems quite a high risk score. The other thing, I wasn't clear about the estates risk that I know John's just mentioned. It talks about, as John's just kind of alluded to, it's a very, very specific risk. And I wonder why it's scoring the way it is. But for me, I think that we have got a strategic risk in relation to our estates, but it's not specific to, you know, whether or not we are responding relating to changes in working practices. Now, I know we don't have an estates risk on the corporate risk register either, but this seems to be a very high risk that we're carrying at the moment. And of course, we've had a number of individual estate issues that have happened in the last 12 months that have caused considerable disruption to patient services. So without it being on the corporate risk register, I would have thought it would need to be on the BAF, because actually it is a key strategic risk. But it's not the risk that is worded there, and I would have expected it to be at a much higher scoring level, given the risks we're carrying.
Louise, did you want to respond?
Can do, and Mark may want to comment as well as the risk owner. I mean, I guess from my perspective, I think there is more we can do around the sort of overarching risks as they're denoted on the BAF around estates. I think there are some opportunity there to kind of bring those together a little bit, and actually give us a risk that's probably more reflective of some of the issues that you've mentioned there, Lucy. So I think there is some opportunity to do that, and we have in a past risk management group opened that discussion, so I think there is more we can take forward on that, and Mark will want to comment.
Yeah, thanks, Lucy. You know, I accept that, and I think that is a wording that we could look at. I think we cite agile working as an example, and that's actually an opportunity for us in the post-pandemic world to potentially look to rationalise our accommodation and the size of our estate. Yeah, estates does feature in a few places, doesn't it? So I'd be happy to take that away and work on that with support from Louise and her team.
Thanks, Mark. I think that would be helpful, because whilst I think the agile working side of it is more of an opportunity than it is a strategic risk, whereas the issue that we've got with our estates across the board is very much a strategic risk that we're carrying. Thanks very much. Happy to assist as well if that would just help.
In terms of security, we discussed that earlier, Louise, under the health and safety update, didn't we? In terms of the business case, any review of the risk will need to take account of what happens to that business case. So we may as well wait to see what happens with that first, I think.
Yeah, that's fine. And we do have, as I think has been mentioned, a deep dive on that particular BAF risk at the next RMG in August.
Okay, all right, that's helpful too. Thank you. John?
Thanks, Mark. It was just on that point with regard to the security one. Lucy had reminded me, because we don't see this risk at DIGC, but I brought that to the board's attention in terms of the CCTV side. And whilst there's a business policy, a business case going through, do we need to make sure that the review is taking account of those issues that have been raised through DIGC in terms of the use of CCTV and the potential risk against breach of legislation and things?
I did actually note that in my pad here, as you mentioned that earlier, John, in terms of the feed through into the next review of that particular BAF risk, because I agree, I think that does need to be reflected and then considered in the round. So yeah, we will have that one as a takeaway. Thank you.
Thank you.
Okay, so we ought to again note, Louise, the positive observations that were made by John and Louise and Lucy about progress. So thank you for that. And we will do what you've asked us to do, and that is to receive and note the report. A couple of things have been identified that I'm sure you'll respond to. And so without further ado, we'll close the item there.
Thank you.
Thank you. So we are now at a lunch break. 20 minutes was allowed previously in the agenda, so I intend to stick to that, if you don't mind. It's 1 o'clock, so can we reconvene at 20 past, please? Diolch yn fawr. See you in a moment. Thank you. Okay, it's 1:20. Shall we get going again, please? And the next item is the updated Health Board Risk Management Strategy and Policy, which is shown as with you, Jill.
Thank you, Mark. Indeed, it is with me, but I believe we've got Simon Evans in here to take us through the changes that have been made, if I may hand over to him.
Of course, yeah. Simon?
Thank you, Jill. So the revised risk management strategy has been through the audit committee. It is revised and tweaked and nuanced rather than a fundamental review. Broadly, I suppose, as covered in the paper, we've made some adjustments to the risk appetite framework. The main one of those is to have in place a pre-agreed a changed risk appetite for exceptional circumstances, which should we have, as we've had in the past 18 months, a significant impact on the health board, have to go into Gold Command, we can have a revised risk management framework, put a revised risk appetite statement put in place, rather than having to do that at the time. We've tried to make it clearer in terms of the horizontal collaboration across BCU, and greater emphasis there on divisions and directorates talking to each other rather than relying on the risk management group to collate risks for escalation, which we think will strengthen the strategy. And we put in clarification of the risk escalation process, particularly around board ownership, and board having the or board committees having the ownership of accepting or de-escalating risks onto tier 1, because as you'll recall in the original strategy that was agreed 18 months ago, that was the intention, but it said slightly different things in different parts of the strategy. So I think those are the key elements that I'd like to highlight for you.
Simon, so, and it has been through audit committee, and Medwin referred to that as chair assurance report earlier on. So that being noted, are there any observations, questions? John?
Thanks, Mark. Thanks. Only one small minor one, which is on the cover sheet in the risk analysis bit. It talks about controls, such as number 2, the risk management training program in place and being delivered. And somebody might see this as semantics, but for me, that's not a control yet because it hasn't actually been delivered. If you think of an analogy with a car, if you have one lesson and you go and drive a car, you're not really in control of it yet, are you? You're only in control of it once you've had all the lessons and you passed the test. So it just feels like, are we being clear enough in terms of what really is a control? And if to control things, we are going to train people, then either all the training has to be delivered, or we have to be clear about what's the body of training that has to be delivered before we feel it's an effective control.
And the effectiveness of this control will develop over time as more people come in, and we can ascertain the effectiveness of the. I mean, I get your point, but at some point it does become a control that we've trained, 1,000 members of staff, etc. into this. So it's fluid and dynamic in terms of a control, isn't it? In terms of the effectiveness of it as a control.
Okay, I suppose I'm reaching for something that's more definitive, that says it's a control when we reach this body of delivered training. But it's one example. That's the only observation I have at the moment.
No, it's a fair point.
Okay, thanks, John. Any other observations or questions? I have no hands showing. I don't have anything. So that comment having been made, we're asked to ratify the revised risk management strategy and policy, it having been through audit committee. Are you happy to ratify?
Yes.
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 Good.
Thank you.
Thank you.
Right, Mark, we now come to the annual plan for 21-22. This, like the last document, has been to a variety of destinations en route. So over to you, Mark.
Okay, thank you very much, Mark. So from a board perspective, we approved a draft plan back in March, in line with Welsh Government expectations. At the end of June, we then submitted a refreshed plan, and this is that plan, and it's presented here to the board for approval. We've not had any feedback from Welsh Government since we submitted our plan to them. We do know that they will not be approving any health board plans this year in the way that they would do under normal circumstances. So we have had some positive feedback on a draft that we shared in June, but nothing more formal from Welsh Government as yet. As you said, Mark, it's been through a number of different board and committee meetings, but I just wanted to run through the changes that have been made since the draft plan we had at the end of March. We've obviously updated the activity and the modelling and all the bed capacity, demand and capacity work more generally to reflect the actual experience that we've had over the first quarter of 21-22. We've received additional resources for planned care recovery, just under 20 million. Those are reflected in the plan. We've now got an EQIA screening assessment and also an assessment against the socio-economic duty, which was introduced from the 1st of April of this year. We've attached for your review an executive summary on the basis that will help us when we come to talk about the plan with our partners and other stakeholders. And I'm very grateful to the support that comms colleagues have provided, because we do also have an easy read, more publicly oriented versions that's subject to the board's support. Today, we will be able to use those immediately in our dissemination of the plan. We've developed programme action plans, which are split into two. First is a full set that we intend to use as an executive team across the organisation, and then we've got a more distilled down version of between 80 and 90 we intend to report to this board, part of our monitoring of progress against the plan. Focus on getting those as smart as possible, with I think the caveat that not all are as easily measurable. Nonetheless, we've continued to work at that. We have also changed the financial forecast, but I should perhaps give Sue the opportunity to comment on the financial aspects of the plan, which I'll do shortly. Yes, just to conclude my opening comments, if I may, Chairman. We're now 4 months into, at the end of July, we're now 4 months into the year to which this plan relates, and it's less than 6 months from when we intend to bring to board an approvable 3-year IMTP for the Health Board. So that is the context in which this plan is presented, and I'd commend it to you for your approval. Obviously been supported by the executive team. So with those comments, I'll just hand over to Sue H to see if she wishes to add anything from a financial perspective. Thanks, Mark.
Thanks, Mark. Sue.
Thanks, Mark. From a financial perspective, the main difference between the draft plan that we discussed in March and this revision that has now been submitted to Welsh Government is around the year-end position. So we've moved from a 28.3 million deficit potential to a break-even position. And this is entirely due to Welsh Government confirming that we will get funding for the impact of the non-delivered savings from last year for this year. So that is a really positive step for us. And it means that we are going to be able to plan for a break-even position for the second year running. So that's taken us 2 out of the 3 years required for the cumulative break-even position, so which is really positive. And obviously, this is dependent upon the discussion that we've already had about the finance paper in relation to the delivery of savings this year. So that's all I'd say at this point, unless there are any questions. Thank you.
Okay, thanks, Sue. Any observations or questions? Lucy.
Thanks. And I just firstly would like to acknowledge that, you know, the changes that Mark referred to, the various iterations that we've received, it has, you know, we can see the feedback that's been taken on board. And I think the plan that we have for this next year is a considerable improvement on previous years. So thank you for all of the effort that's been put into that, and Jo for her leadership on this as well. Just 2 points from me. The first one is, we had previously discussed the fact that the plan would be flexible, recognising that things may change quite rapidly, particularly as we're cases are starting to increase again in the community. So could you just confirm that's still the case? And secondly, then, in relation to the action plan, I note, Mark, that you said that's going to be for use by the executive team. Could you just provide assurance that the actions within there have been cross-referenced to the plan, as the link for some of these aren't immediately clear? Thanks.
So thanks, Lucy. So absolutely, plans need to be flexible and dynamic. I think that's true. Any circumstance, I think it's even more true in the current year. And the changes, even from end of March to end of June, really kind of speak to that. I think at the end of June, we did propose a process by which the plan could be amended. Having secured board approval, we need a robust process to make changes to the plan. But absolutely, I can give you that assurance that the plan needs to evolve as we move through. I think on your second point, Lucy, about the alignment between the programme action plans and the narrative plan, yes, I'm content with that. Probably difficult to say that we can't find one action that's in the plan that's not in the action plan, but we have developed them in parallel, and I'm confident that there is a high level of alignment between those two things. As always, I think the proof of this will be in the kind of the tasting as we kind of move through. Perhaps just say a little bit whilst I'm speaking then about the monitoring of the plan, because we have already started with my executive colleagues collating where we think we are at the end of July, or where we think we'll be at the end of July, I should say, and we intend to report that to I think it will be PPPH and PFIG in August. So that's when we will commence the plan monitoring, and that will probably allow us to test the smartness of the objectives a little bit in action at that stage.
Thanks, Mark.
Hey, Linda, I think you have a question.
Diolch, Mr Cadeirydd. Ga I just ofyn, wrth bod Lenni fydd tro cyntaf, bydden ni'n gorfod adrodd yn ôl ar y ddyletswydd economaidd gymdeithasol. Be di hyder ni gyd bod hyn yn mynd fel da ni ddisgwyl, a bod y tystiolaeth bydd gennym ni angen yn mynd i cael ei gasglu ac yn cael ei rhoi fewn wedyn i'r broses o cynllunio? Diolch.
So our compliance with the full range of equality duties, including the new socio-economic assessment, is monitored by what has been SPPH. So we've got those organisational systems and processes in place. We've worked very closely with Nia and colleagues putting together this initial assessment. It is a new thing for us, and we're all learning. So I'm sure it'll be possible. I'm sure next year's can be a little bit better. The assurance I would offer to the board is, I think the role of SPPH, as has been in monitoring completion of these assessments.
Ydy hyn yn rhywbeth mi fyddwn ni'n gofyn i Llywodraeth Cymru am barn ynglyn â'r ffordd da ni'n adrodd ar hyn?
I would imagine that this will form part of their inspection regime and the various audit and other assessments that we are subject to as a health board. So as a new duty, if I think about the well-being of future generations work, for example, which has been around for a number of years, there are frequently assessments that wend their way through to the audit committee, where we are required to offer evidence of our compliance with those expectations that are placed on us.
Okay, diolch yn fawr.
There is a national Building a Healthier Wales coordination group, of which I'm co-chair, and which is due to meet with the Minister quite soon, wherein we're offering to coordinate the response to health inequalities across Wales. So I think as that dialogue develops and the offer is presented from that group to the Minister, and assuming she takes it up, there'll be more information being disseminated from that group about how we respond to health inequalities across Wales and also how we report on our responses to them.
Mae hwnna'n peth braf iawn I glwad, achos fel dyletswydd newydd, a fel rhywbeth sydd yn amlwg yn bwysig yn rhaglen Llywodraeth Presennol, bydd o'n braf cychwyn a ryw nodyn positif iawn ar ran ein ymateb i'r dyletswydd. A mae braf glwad bod yna gymaint ar y gweill ar hyn o bryd. Diolch yn fawr.
There is, and Tracer's aware of that group, and I know he's tapped into it as well, so she can provide the executive link to the work that's going on. So thank you. Thanks for the question. Mark, I've got a question myself. So you've touched on the reporting. So I think we're agreed, aren't we, that it's a bi-monthly reporting via committee to board, that you report on detail on the actions that are being shown as either amber or red. So not on track or there being a concern. And in doing so, that will free up the performance team's time to a degree, at least, to keep an eye on the evidence around the green recorded actions in terms of progress, so as to provide some assurance to the board that those are continuing to be monitored.
Yes, yeah, that's exactly the case, Mark.
Okay. Second thing is, Mark, there's reference in the covering report to a focus on accountability. Can I just check where the executive team stand on the level of assurance you're able to provide or not around the implementation of the new performance and accountability framework that we agreed a little while back? I'm concerned about mixed messages and the potential that it's not currently consistently and coherently in place. What's your view?
I'll comment on that, and I'll perhaps invite Jill to comment. Jill chairs the performance oversight group that's set out in the new performance and accountability framework. I think it's work in progress. We've got another round of executive divisional accountability meetings coming up on the 26th and 27th of July, I think it is, so the week after next. That's where we meet as an executive team with all the divisions. We've got the agendas agreed for that. That's already gone out. So I think we're starting to embed that. I think where we've got a little bit more work to do is that is intended to be close to the kind of top of the triangle almost. And if I use secondary care as an example, but it works for other areas as well, we want to meet the secondary care divisional team, but we rely on them having had their own internal processes where they've met with 3 hospital sites. And there are similar arrangements within primary and community services, for example. So I think from the work we've done so far and what we've observed, those arrangements are not as well developed. So I do think there is a bit more work to do in that space. I do think we need to stick with an approach. It's as set out in the approved performance and accountability framework. Really give it a good go, let it settle in, let people get used to it, and then we'll be in a position to take stock and see if we need to change our approach any. Thank you.
Jill?
Just to support some of what Mark said, we had a good debate at the last performance oversight group about how we use the data to inform the questioning, but also make clear that it's aligned to the priorities. So it has been work in progress, but we're really clear that the next set of accountability reviews are aligned to the plan's priorities as opposed to other things. And that we are gradually improving our use of data. So we're focusing the questions in the right area rather than having a single script. So it is work in progress, but I think the process is being strengthened. And I would say the input from the other execs in developing how we reframe those questions and get the assurance, and that may include different ways of looking through the lens, so on a locality basis as well as through purely a secondary care area, because the interdependencies are so critical in delivering our objectives.
Okay, thanks, folks. So bearing in mind the performance oversight group should feed into Finance and Performance Committee under the governance structure, which we'll come on to in a moment. Could you agree with John that when you're likely to report on a stock take against the performance and accountability framework? I mean, there's lots of stuff going on, but I think it'd be helpful to that assurance to be provided by John or to John in that committee when you're ready.
Yeah, we can do that.
Thank you. Thanks. Okay, so I don't have any other hands raised or signals of questions, so the board is asked to approve the plan. Are colleagues happy to do that?
Yes.
Yeah.
Thank you. So we now move on to Teresa. Teresa, Welsh Language Standard 37 and all that goes with it. Over to you.
Diolch yn fawr, Cadeirydd. Cawson ni drafodaeth mis Tachwedd llynadd i drafod safon 37, sydd yn un o'r safonau y Gymraeg ar gyfer ni yn y Bwr' Iechyd. Ar y pryd, nathon ni gytuno symud ymlaen o ran cyfieithu rhywfaint ychwanegol o bapura, sef yr eitema sydd yma fel papura sefydlog i'r Bwrdd Iechyd. A nathon ni gytuno ar y pryd ar ôl sgwrs go hir, swn i'n dweud, ynglyn â sut oedden ni'n mynd i cyrraedd y safon, nathon ni benderfynu fysa ni'n asesu'r sefyllfa ar ôl 6 mis. Felly dyma'r papur sydd yn rhoi rhywfaint o wybodaeth i chi ar ôl y 6 mis a'r asesiad sydd wedi cael ei gynnal, ond hefyd yn rhoi awgrym ynglyn â sut fysa ni'n gallu symud ymlaen. Felly diweddariad ydy hwn yn syml, aim dros y papur i gyd, mae papur byr ydy o. Ond dwi'n meddwl bod o'n gadarnhaol i ni nodi nad o' 'na broblemau mowr wedi codi yn ystod y 6 mis. Mi nathon ni gallu wneud yn siŵr fod y papura yn mynd allan ar amser. Diolch i bawb yn swyddfa bod yr ysgrifenyddes. Mae hynny yn rhywbeth bwysig dros ben i ni. Ond ar ôl deud hynna, mi welwch chi o'r gwaith papur, mae eitha bychan o nifer o eiriau gath i gyfieithu'n ychwanegol yn y diwedd, rhyw 20,000 o eiriau ar gyfer un cyfarfod. Dwi'n deud hynny oherwydd mae'r tîm wedi bod wrthi'n edrych ar y papur ar bwrdd yn ei cyfanswm, ac yn ôl beth dwi'n dallt, mis Mai, os fysa ni wedi cyfieithu pob un gair yna, mi o'na 480,000 o eiriau yn y bwndel o bapura a allan i bobl. Wedyn mae yna cryn waith i wneud os fysa ni'n cwrdd ac cyfieithu bob un papur sydd yn mynd trwy y Bwrdd Iechyd fel hyn yn yr cyfarfod yma, sef y Bwrdd Cyhoeddus. Felly, mae'n gadarnhaol beth da ni wedi dysgu o'r 6 mis. Da ni'n gwybod fedra ni'n neud y gwaith, da ni'n gallu cyrraedd yr amserlen. Mae hynna'n bwysig, oedden ni'n pryderu am hynny ar y pryd. A da ni eisiau wrth gwrs cyd-fynd hefo'r safon a cyd-ymffurfio'n llwyr. Da ni wedi cydnabod pwysigrwydd symud tuag at cyflawni safon 37 yn ei gyfanswm fel petai. Wedyn, da ni dal ar y siwrne i wneud hynny. Rach bod o'n bwysig i mi ategu o ran y safon 37, sy'n rhaid i ni cyfieithu bob un papur, ond mae angen i ni edrych yn ofalus ar y papura be di'r angen. Wedyn, mewn ffordd, dwi'n awgymell ar hyn o bryd fod ni'n gwneud chydig bach mwy o waith am 6 mis arall, gyda help swyddfa ysgrifennydd y bwrdd, i wneud yn siŵr bod ni'n dallt beth ydy'r her o'n blaenau ni, oherwydd dwi'n isio gaddo i'r bwrdd fod ni wedi gallu wneud hyn os fedra ni ddim o ran yr ochr practical ac ymarferol i'r tîm i gyd, oherwydd mae hwn yn rhywbeth sydd yn heriol o ran amserlen y Bwrdd Iechyd. Wedyn, beth ni'n awgrymu ar hyn o bryd ydy fysa ni'n cynnal asesiad chydig bach mwy manwl tro hyn, gan ddefnyddio templed ac da ni wedi bod yn trafod hefo swyddfa ysgrifennydd y bwrdd i wneud yn siŵr bod gynnon ni templed sydd yn edrych ar y gofynion. A mi welwch chi yn y papur bwrdd bod ni'n awgrymu bod ni'n edrych ar y gofyniadau cyfieithu o flaen llaw, ond bod ni'n wneud yn siŵr bod ni'n edrych ar beth ydy'r gofynion, pa bapura sydd wir angen i wneud, pa rei sydd fwyaf pwysig ohonyn nhw i gyd. Hynny yw bod ni'n proportionate mewn ffordd, bod ni'n edrych ar y gwaith yn ofalus yn symud ymlaen. Ydy'r pwnc o ran diddordeb i'r cyhoedd yn bwysig? Ydy'r asesiad ieithyddol yn bwysig o ran y boblogaeth yma'n Gogledd Cymru, ac wrth gwrs mae nifer o papurau yn hynod bwysig. A fydd y papur yn denu ymateb gan y cyhoedd, ydy hwnna rhywbeth i ni ystyried. Ac wrth gwrs, oes a gofyn i'r cyhoedd ymateb i'r papura. Mae'n bwysig felly fod y papura ar gael yn hollol ddwyieithog. Wedyn, pwrpas y papur o dod ar diweddariad i chi. Sa ni wan yn licio wneud 6 mis arall i ni ystyried y ddwy swan faint fwy sydd angen I wneud gan gofio fod capacity'r tîm fewnol iaith Gymraeg wedi cyrraedd. Maen nhw'n barod hefo fwy o waith na sy'n o tîm. Da ni'n gyrru'r gwaith yn allanol fel y gwelwch chi o ran y costa, dyna oedd y cytundeb ym mis Tachwedd, mae hynna wedi gweithio yn dwt ac yn daclus, ond o symud o 20,000 o eiriau I 400,000 plus o eiriau, mae yna ofyn mowr wedyn. Dwi'n argymell i'r bwrdd bod ni'n mynd ati defnyddio templed, asesu gweddill y papurau rwan I weld pa papurau eraill sydd angen I cyfieithu a be fydd yr oblygiadau I ni fel bwrdd iechyd yn symud ymlaen. Dwi'n meddwl fysa hynna yn helpu ni I wneud yn siŵr bod ni'n penderfynu'n bwyllog, bod ni'n wneud yn siŵr bod ni'n gallu cyflawni gofyn yn arddewid i'r bwrdd ac i'r poblogaeth o ran yr iaith Gymraeg. Ond mae hynna hefyd yn symud ni mlaen fel bod ni yn gwella mewn ffordd yn darpariaeth o ran safon 37 a bod ni yn trio dal ati I symud ymlaen hefo cwrdd yn llawn ag anghenion safon 37. Dwi'n meddwl bod y papur yn glir o'r arall, ond dwi'n fodlon cymryd cwestiynau a diddordeb wrth gwrs y marn y bwrdd.
Diolch yn fawr, Teresa. Linda, as the Welsh language champion, I'm going to ask you to comment next.
Diolch yn fawr, Mr Cadeirydd. Yn gyntaf, ga I ddiolch I bawb sydd wedi bod yn nghlwm gyda'r broses o baratoi'r adroddiad a hefyd yr holl gwaith cyfieithu papura dros y 6 mis dwytha. Fel person sydd yn defnyddio y fersiynau Gymraeg ers I mi dechrau ar y bwrdd, dwi'n croesawu'n fawr iawn y cyfle I darllen y papurau yma yn y Gymraeg a hefyd gael tegu bod safon y gyfieithu yn uchel iawn ac mae hwnna hefyd yn bleser ar ran weithiau ydych chi'n cael cyfieithiadau sydd yn anodd iawn yn wedi greu technegol, ond mae'r safon chwarae teg yn un sy'n darlleniadwy a dwi'n siŵr byddai'r cychoedd yn ei werthfawrogi. Ga I gefnogi y cynnig mae Teresa wedi rhoi yn ei prynhawn yma. Dwi'n meddwl mi fyddaf yn doeth I ni edrych yn ymarferol ar be fydd yr anghenion, a be fydd yr anghenion mwyn gwella ein gwasanaethau yn y Gymraeg ar lefel y bwrdd ac wrth gwrs ar lefel Pwyllgoron ogystal. Dwi'n bodlon iawn gyda'r cynnig mae Teresa wedi rhoi i ni, sef I edrych yn mwy fanwl hwyrach ar yr anghenion, I dod yn ôl gyda cynnig hollol ymarferol ar ran gallu sicrhau bod ni'n cyrraedd y nod, ond hefyd mewn ffordd sydd yn hefyd yn rhoi gwell gwasanaeth I bobl sydd isio derbyn yr holl gohebiaeth yn y Gymraeg. Diolch.
Diolch, Linda. Efion?
Diolch yn fawr, Mr Cadeirydd. Dwi'n cefnogi llawer o sylwadau mae Linda wedi wneud. Da ni'n mynd y cyfeiriad cywir ar y mater yma, dwi'n credu. Ond ar ôl deud hynny, mae yna bron I 2 blynedd I mynd heibio pan gathon ni'r rhybudd gan y Comisiynydd Iaith. A fysa ddigon hawl dadle bod ni ddim yn symud ymlaen digon cyflym, I fod yn onest. Un o pethau nes I y dyddiau dwytha yma, edrych ar safle we bwrdd iechyd Hywel Dda I weld sut ydyn ni'n cymaru. Ac I ddeud yn ysgafn, da ni ddim yn cymaru dda. So felly, my fod I'n cefnogi'r argymelliad yn y droddiad, fyswn ni'n awgrymu Teresa yn ysgafn I chi, bod ni'n edrych I weld be mae byrddau iechyd yn neud, eraill yn neud, a sut maen nhw'n cyflawni ar y safon yma yn ystod y 6 mis nesaf, ac adrodd yn ôl ar hynny hefyd I weld yn union beth yw'ch cymhariaeth chi hefo y gwaith maen nhw'n neud. Mae'n amlwg bod nhw hefo llai adnoddau ni, adnoddau ar y wyneb yn bwrdd iechyd Hywel Dda na ni, a maen nhw yn gallu weld I fi wneud y well ar hyn o bryd. Mae adael ar hynny.
Teresa, do you want to comment?
Diolch sylwadau Linda ac Eifion. Mi awn ni ati edrych ar byrddau eraill a be maen nhw'n I wneud. Da ni'n gwybod bod gyda nhw heriau hefyd, a da ni mewn trafodaeth oherwydd, wrth gwrs mae'n pennaeth iaith ni yn siarad yn agos fyna, network wrth gwrs o swyddogion yn gweithio ar draws Cymru, ac dwi'n gwybod fyna heriau eraill ar draws Cymru. Wedyn awn ni ati I roi pisin at ei gilydd I ddangos, I ddadansoddi mewn ffordd lle yda ni o ran y cyfieithu ar safon 37. Wrth gwrs, mae yna meysydd eraill lle swn ni yn awgrymu da ni hefyd ar y blaen, ond fyswn ni'n neud hynna dim problem Eifion a dod â hwnna nôl yn rhan o'r papur mewn 6 mis. A hefyd fyddwn ni'n cael trafodaeth yn y fforwm, a mae hwnna'n nôl a fedra i cael sgwrs wrach fwy anffurfiol cyn dod â'r papur i'r bwrdd yma.
Diolch yn fawr.
Thanks, Teresa. And I met with Larry, the head of Welsh language team, on Monday for a catch up, and she certainly was supportive of the approach you described in the paper, and no doubt it was co-produced with her, particularly to understand the practicalities of translating the scale of papers that we have at board, some of the information contained with them. So I think everyone's agreed that we'll go with the recommendations in the paper on that basis, and let's see what that analysis tells us about what we should do and what we could do moving forward, and understand in that regard the resource information too of taking those steps now. Just as an aside, Teresa, I agree with you, Larry. There will be a slot at the next board workshop on the 5th of August to provide further Welsh language input to the board members. Could you and Linda agree with Larry the best use of that time? She said that the Tuesday would only need an hour, but if we were to adjust the agenda, I'm sure we could find more time on that particular topic, and I'm keen to do so if you and Linda felt it would be helpful.
Diolch yn fawr Cadeirydd. Na i gair efo Linda ag Eleri wrth gwrs, ac da ni'n ddiolchgar o'r cyfle ac yn ddiolchgar am y cefnogaeth wrth gwrs hefo'r gwaith yma, hefo'r gwaith y papur ar bwrdd hefyd. Diolch yn fawr.
Teresa. So I will now move us on again to the integrated governance framework. And Simon, Jill, I'm conscious of the fact too, this item has been to many destinations en route to here, and it's been the subject of some considerable discussion. So with that in mind, I'll hand over to you.
And with that in mind, I'll hand over to Simon, because I was just going to say exactly what you've just said, Mark.
Okay, good. Simon.
Okay, I can't turn my video on for some reason or other. I think it says it's been stopped, so forgive my just voice. Yes, this has been through a number of places. It went through the audit committee. We had a long and good debate about the framework in the board workshop, since when some of the comments there have been taken on board and included within this document that you see before you. I would just stress that it's a framework, and therefore there may be some minor changes to it as we move into the implementation framework, into the implementation phase, but nothing I don't think would be substantial. So I commend the report to the board for approval.
Thanks, Simon. Any observations from anyone? Lucy.
Thanks, Chair, and I very much welcome this framework. It's been a long journey, hasn't it? And thanks very much for all the work that's been put in by the team. I'm glad as well that you've mentioned, Simon, that there'll be tweaking as we go forward, because at the end of the day, although we may be approving this particular framework today, I mean, it may need to flex as things start to bed in, but this should enable us to actually get that structure and stability across the board and improve governance. I was also really pleased to see the addition of a patient story to the board agenda. As you know, I've introduced patient stories now to Together for Mental Health Partnership Board, QSE Committee and the Mental Health Act Committee, and it's really helpful in keeping us focused on what we're here to do, which is all about the patient and learning from their experiences. So I think it's a really powerful tool. I'm really pleased to see that on the board agenda. I do think quality and patient safety needs a higher profile still as part of the cycle of business. But again, I'm sure we can pick that up as we go along. My final point then is that there are a few minor inconsistencies across all of the documents. Can't imagine why with the hundreds of pages to work through. But they are not substantial to such that they would affect any approval today. And I'm happy to pick that up with you and John outside the meeting.
Thank you very much.
Thank you very much.
Thanks, Lucy. John.
Thanks, Mark. I think colleagues know that I was expressing some concerns about this in terms of things that were missing. I recognise that after some discussion, some of those concerns have been addressed, and I welcome the comment as well in terms of being able to tweak this as we go forward a little bit, because although not everything that I was concerned about has been dealt with, the more substantive issues have been covered. So happy to sign up to this as it stands, as long as we have got that little bit of flexibility as we go forward to tweak as we learn from the process.
Thank you, John.
Yeah, and that's fine. So happy to proceed on that basis too. Okay, any other questions or observations? No, okay, so we are now asked to approve the governance framework and all that goes with that framework as set out in the appendices. So are board members happy to do that?
Yes.
Yes.
Thank you. Thanks, everyone. Thanks, Simon, for your work, and Jill, your work on this. Good place to get to, important subjects. Thanks very much.
Thank you.
Thank you. So team effort, and really welcome the input of board members.
Great, thank you, Jocelyn Al-Yow. So we'll now move on to the PET programme business case. Do we have who we need here?
Chair, I think Judith is joining, and I can see Andrew Champion, has joined. But literally, but I don't know which exec is going to take the paper.
Right, Andrew, I'm not getting any offers. Are you able to fill the paper or not?
Myself?
Yeah.
Yeah, there should be, Sean Lewis should be joining us, who's the Managing Director of WISC. Check that Sean's with us.
So we're expecting Sean and Sarah, I've got listed, Andrew.
Yeah, unfortunately Sarah's unwell. That's why I'm attending on her behalf. So I'll be giving you an overview of the programme business case, if that's all right.
Andrew, it's Jo Whitehead here. I was certainly expecting Sean to join us. In fact, she and I have had a conversation about her presenting this paper at the board. Through you, Chair, I'll just see if I can find where Sean is. I've got her contact details, if that's okay. Andrew, would you feel comfortable to start us off just while I'm trying to locate Sean?
By all means, yeah, I'm very happy to do so.
Diolch yn fawr.
Croeso, no problem. Pnawn da pawb. My name is Andrew Champion. I'm the Assistant Director of Evidence Evaluation at WISC, and I'm stepping in this afternoon instead of Dr. Sarah McAllister, who's the programme lead for the PET programme business case. Unfortunately, she's unwell. I'm the Deputy SRO for the programme, and Sean Lewis, who's the Managing Director of WISC, is the SRO for the programme. I'm just going to provide you with a brief overview of the programme business case, and I'm very happy to take questions at the end if there are any, if that's okay with the chair. I think Sean's just joined us, actually. I can see her now.
Okay, it is, yeah, Andrew.
Thank you very much. So I'm just going to very quickly go through the rationale behind the programme, some of the key issues and challenges that were facing or currently face the Welsh Pet Service, how the programme business case was developed, and our plans to implement the recommendations within the programme. So way back now in 2018-19, a number of key strategic documents were published that highlighted the critical issues facing imaging services across Wales, but in particular PET. So we had the statement of intent that was published by Welsh Government, but we also had a report from ORPET, which is the All Wales Pet Advisory Group, spelling out the very stark situation that the pet service was in and continues to be in. In 2019, Andrew Goodall invited WISC as Commissioner of PET in Wales to develop this programme business case, setting out the capital infrastructure requirements in Wales for the next 5 to 10 years. And we appointed a programme manager late in 2019 with funding from the NHS Collaborative. And in early 2020, we set up a multidisciplinary PET programme board. And this programme board reports directly into the National Imaging Strategic Programme Board. That board was chaired by Sian and was multidisciplinary. It had members from all the health boards and Velindre NHS Trust, planning leads. It also had representatives from each of the 3 PET centres across Wales. So it was highly appropriate membership. For those of you who don't know, PET scanning is an imaging technique and is a subspecialty of nuclear medicine. It's highly technical and quite specialised. It's a diagnostic and staging tool primarily, mostly used in oncology, but increasingly now being used in other areas such as cardiology and in mental health and also inflammatory disorders. The advantage of PET is that it provides, in many instances, better diagnostic accuracy than other imaging techniques. And this enables clinicians to change patient management appropriately and give them the most appropriate treatment, thus avoiding inappropriate treatments and making more cost-effective decisions and leading to better patient outcomes. So the issues facing PET back in 2020 and continue to face us is that it's pretty stark, really. We currently have 0.6 PET scanners per million population. The Royal College of Radiologists recommends 1, and actually we should aspire to 1.5 scanners per million population. We currently perform around about 40% of the scans that are carried out in NHS England, 40%. We only have 1 static PET service, which is in Cardiff, and that's now working beyond its recommended lifespan. It's a very aged machine. We have limited access to clinical trials, therefore, for patients. We have mobile scanners in Wrexham and Swansea. These can be unreliable. It's a poorer patient experience getting to them as well, and they often have to be transported elsewhere throughout the week. We also know that our population in Wales is ageing, and we know that there'll be more people accessing PET in the future. The workforce issues are challenging. Technology is moving on rapidly, newer machines, newer radiopharmaceuticals. We also know the demand for PET will increase year on year. We estimate 20% growth in PET scans between now and 2031. But there are positives. We've got a cyclotron in Cardiff, which is a great research facility for the whole of Wales to provide novel radiopharmaceuticals. We've got a skilled and experienced PET workforce, which and they're really enthusiastic about what they do. We've also introduced 20 plus new indications in the last 3 or 4 years that WISC have commissioned. So things are moving, but not quite as well as we'd hoped. So the programme business case, it was developed with rigour, extensive engagement and input from many key groups, not least the health boards from across Wales, but also from Velindre, Welsh Government, HEIW, Shared Services Partnership, Imaging Academy, I could go on. We set up 5 separate task and finish groups, which are the clinical workforce, finance, R&D and radiopharmaceuticals, and they were basically the driving force behind the programme business case. We also brought in an external consultant to help us develop the economic case through a series of workshops with the programme board, and that was a really pivotal, important development. And so the process of drawing up a long list of options for the programme business case was developed, and this was assessed by agreeing a series of critical success factors and agreeing the options framework. And then what we did, we discounted those options that didn't meet the spending objectives and the critical success factors, which left us with 4 shortlisted options, which are in the programme business case. Each of these then underwent a full economic appraisal. We looked at the costs of each of those proposals. We looked at the benefits for patients and the wider community. And we did a variety of sensitivity analyses as well to give us some sense of feeling of around some of those costs. The preferred way forward, the option that we'd agreed with the programme board, was for 4 fixed site PET scanners across Wales by 2031. The first bit of that would be initially to replace the old scanner in Cardiff and then to replace the mobile services in North and South West Wales. The location of a 4th scanner, that will be taken at a later stage. The total cost of the programme we estimate to be £25 million. And this will be used to meet the spending objectives and realise hopefully the benefits for patients. Implementation will be phased to allow development of individual business cases as time goes on and to address any and all infrastructure issues. And one important question, obviously, is revenue costs and where will they be generated from? Clearly, this is very important. PET is a specialised service commissioned by WISC. We pay per scan. And we will see continued growth in demand for PET, 20% per annum per year for the next 10 years. And this funding stream should ensure enough revenue to meet those needs in terms of infrastructure, staff, etc. We've set out a clear programme structure to implement the PBC. We set up four work streams have been proposed: radiopharmaceuticals, workforce, centres of excellence and procurement, and this work is now underway. And finally, the programme has been subject to a programme assessment review by Welsh Government. This is part of the scrutiny process that the Welsh Government apply to all these types of bits of work. And we are now implementing their recommendations, and they include things such as benefits identification, mapping those benefits to measurable patient outcomes, strengthening the procurement strategy and requirements, and finally establishing a programme management office capability in order for us to run the programme. I'll stop there, and hopefully I haven't gone over, and I think we're happy to take questions.
Before I go to questions, Sian, good to see you again. Is there anything you want to add?
I just want to say we've had great engagement from your team in North Wales, Mark Elias, and I'm afraid your radiography manager's name has just popped out of my head. Andrew, can you help me? David?
I can't remember, unfortunately.
It's David. Anyway,
David
we've
Jones,
had absolutely...
David Jones.
Thank you. We've had great engagement and support from them, and I just really wanted to mention their names.
Yeah, Sian. So, questions. John, you've got your hand up. I don't know if that was the last item or a new one.
It was an old hand, but I wanted to put it up for this as well.
Okay, all right then. Go ahead.
Yeah, the thing that just struck me, I think in principle I've got no problems with this at all, but it's just some of the justification in terms of the background. And at the bottom of page 2 on the cover sheet, and it's in the main business case as well, it refers to 33% of PET scans per head of population as a justification that scanning activity levels are low. But I don't know what it's 33% of. So it goes to the justification for this. Now, what is it? What's it talking about?
Compared to NHS England.
So is that 33% of the scans that we should be doing, or is that 33% of, and 67% are therefore being done by England for us?
No. So we have a much lower rate of scans per head of population compared to England. So if you were in England, you'd be much more likely to get a PET scan than if you live in Wales. And if you live in England, you're much less likely to get a PET scan than if you live elsewhere in Europe. So we have a very low level of scanning per head of population.
Okay, thank you.
Andy, do you want to give any more detail on that?
Just to say that it's a slightly false picture. I mean, there is quite a difference, but in Wales we have quite strict gatekeeping about who should access a PET scan. We have a very tight commissioning policy where the indications are very clearly defined. In England, it's less so. They don't have gatekeepers like we do, so there's probably more referrals for PETs going on that perhaps are outside of the list of indications. So I think that's part of it, but also they've got access to a higher number of scanners. And so patient access is much better. I think there's always been a sort of hesitancy, people living a long way from Cardiff to travel all that way for a PET scan. And but now we've got a unit down in Swansea. That's pictures improving.
It doesn't help people travelling from North Wales, though, does it?
No.
No, not at all.
I suppose the other side of this for me is there a contribution in terms of what's needed? Is there a difference in need within the Welsh environment to the English environment or the European environment, or is it? Would your expectations be that the demand should be similar?
We would have thought the demand should be very similar, and we know that there are areas where we're not currently scanning, which patients are having scans for in England. So our range of indications is lower, and for those indications that are the same, we've got a lower rate of scanning.
And that's, as Andy said, partly because of access to scanners. Mobile scanners are much less flexible. So if you have got a mobile scanner on a Monday and a Wednesday, if that scanner breaks down on the Wednesday, you can't scan till the next week. Sometimes treatments are going to go ahead and clinicians will make the decision to go ahead without a scan. So not having a fixed scanner, we think, significantly reduces accessibility to scans, and also it's more difficult for patients with mobility issues. So the mobile scanners are literally on the back of a lorry, and actually if you've got mobility issues, it's much more difficult to get you scanned than if we had a fixed sites facility.
All right, thank you. Thanks, Mark.
Thanks, John, Lucy, and then Joe.
Thanks very much. Hi again, Sean.
Hi again.
You know what I'm going to ask. You've referred to the fact that we've got stricter gatekeeper functions here in Wales, and I appreciate that the comment about that's partly due to access. Is it only due to access, and how does that impact our patients? Because I appreciate that if we don't have access to the scanners, then there's a longer wait for patients trying to access it. But trying to understand as well whether that actually impacts on the outcomes for patients.
So outcomes is always very difficult to measure for a diagnostic test because it's much more difficult to see the direct relationship. But there's lots of indirect evidence that PET scanning improves, particularly in cancer care. Most of the evidence is there, particularly in cancer care. PET scanning much more accurately stages cancers. So it's good data around that. And what that means is, for example, you don't have patients undergoing very long invasive surgery for tumours that are not going to be cured by that invasive surgery, because you've much more higher level of sensitivity for picking up the actual stage compared to other tests. So so all the indirect, there's some direct and all the indirect and lots of indirect evidence that improves outcomes.
Okay, thanks. So that's really concerning then, that we're not, our patients aren't getting that access.
And I think that's one of the really big drivers for this programme. It's a really important driver. Our patients do not get as many scans as if they lived in other parts of the UK and certainly in Europe.
That's really, that's not good at all. Okay, thanks very much.
Lucy, is that your question finished?
Yes, thanks.
Okay, thanks. Joe?
Sean has said much of what I was going to say, so I won't repeat what she said, save to make the observation, of course, that looking at the epidemiology and population characteristics in North Wales, that adds, of course, to the challenges with access and opportunity, volume of need, which this business case in part is designed to help us resolve. Diolch yn fawr, thank you.
Mark, can I just add two more points? One is that there's the scope of the use of PET scanning is developing significantly. It's now starting to be used as a diagnostic test in Alzheimer's disease, in some inflammatory conditions of the heart. So the breadth of diseases in which it appears to be of value is growing. And secondly, one of the questions which I haven't been asked yet, but we often get asked, is how does this fit with workforce? We know we struggle to get people in our radiology departments, but we are strongly of the view that PET scanning makes a department more attractive from a workforce point of view. It improves recruitment because it's a very innovative modality, and I think it's important for the future of our hospitals and services that we are able to that we have this modality available.
Okay.
Could I just sorry, Mark, would I be able to quickly follow on from that, just very briefly?
If you are quickly going to follow on.
Yeah, sorry.
It's been made. We've got a business case to approve or not. So yes, please be quick.
Yeah, I will be very quick. It's just around radiopharmaceuticals and clinical trials. This will widen access for patients to clinical trials that it wouldn't have been able to access up to now, having fixed light scanners around Wales, and also access to really novel radiopharmaceuticals can only be good in terms of widening the indication list for the future.
Thank you. Thanks, Andrew. Thanks, Sean. So coming to the rub of it, the programme business case is before us. Are we happy to approve the programme business case?
Yeah.
Yes.
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 Yeah.
Yes. Yes.
Unanimous support then, as far as I could tell. Sean, Andrew, thank you for your time. Thank you for the work that's gone into this. We look forward to seeing it move forward, and most importantly, look forward to seeing the availability of this modality to our patients and communities here in North Wales. Thanks very much.
Thank you.
Thank you. Diolch yn fawr iawn I chi.
Diolch yn fawr. Hwyl.
Hwyl fawr.
Okay, so we shall now move on to items for information, and they are listed at 5.1 in terms of private session items reported in public. So I'm now closing the business of the public meeting. The date of the next meeting is the annual general meeting on the 29th of July, and the next health board meeting proper on the 23rd of September. I'm now excluding the press and the public, and we will move to private session.